Hello and good evening, everyone. I hope I am audible to all of you. If I'm audible and there are some, can you please put up a message on the chat box so that I know that my audio is clear? I hope my audio is clear, loud and clear. Good evening, everyone. I hope my video is clear. I hope all of you are well relaxed and ready for the weekend or even the IPL matches today. Luckily or unluckily, today is RCB's match. So let's see. I hope you're all ready. Good evening, Dr. Abhirami, Daivik, Narendranath sir. All right. So I'm Dr. Nishanth Lakshmikanta, and I am the surgery subject matter expert for Manipal Medes. Now, at the outset, the idea of this prepathon, okay, basically what we have done is we have tried to cover all the important high yield topics in 21 days. Now, the key to cracking this INICET examination is not by trying to read something new or something like that. The whole idea is you need to work smart and revise, and you need to get your PYQs spot on. Even one question that side this side can make a huge difference in terms of the branch that you want to choose. So revision is the key. Now I'm sure over the last 10 days or so you have gone through all the various lectures. If not, please subscribe to our YouTube channel, click on the bell icon without fail, because you'll be made aware of all the updated content on the YouTube channel, so that you can keep coming back and having a look at it. And at the same time, all our videos are also, whichever have been done in the last 10 days, are available so that you can come back and watch them. Now please keep it in mind, these are all revision videos, so you can even watch them on 2x and cover a lot of content in a very short period of time. Now in general surgery, what I've done is I've not just covered PYQs, I've also tried to target the possible questions which can come based on the pattern of questions that I've noticed over the last 5 years. There are certain topics which they have concentrated upon left, right and center, and that is all the high yield subjects, or sorry, the high yield topics where the questions can come from. So that is the idea of the presentation what I've done today, where I've tried to cover all the major important topics. Certain places I'll go in depth, so please don't lose hope. The minute you look at it, don't lose hope saying, oh, this is so much, I didn't know about all this and all. That is the idea of attending this class, okay? So that I don't want you to go waste time and sit and read up. So just watch this class and you'll get that extra 30% which you would not have read also, okay? So without any further delay, let's start off with one of the most important topics, that is breast and breast disorders. So what we'll do is we'll first talk about carcinoma of the breast. I hope my screen is visible to you. If someone can please put a thumbs up, or is my screen visible? The Manipal Medes INICET Prepathon, is my screen visible? Handwriting is there. Mr. A, yes, sir, can you please take a session? We will do that. We will coming up. Let's tackle one hurdle at a time. It's not worthwhile trying to take too many things at a time. So let's concentrate on INICET, and then once that is done, we will target the NEET PG also. That is the whole idea of this. Okay. Yes, the screen is visible. Thank you so much. Done. So like I said, one of the most important topics is breast and breast disorders. Now, the reason why I say it's very important, I don't know how many of you have noticed, if you open Bailey and Love and look at the last page of breast chapter, you will see that there are at least 4 names of staff who are from AIMS. Okay, so almost guaranteed that you will get questions, and every time they keep asking a new question. So the idea is we are trying to look at those topics which have not been asked also, and I've tried to cover them in this. Now, before we talk about carcinoma breast, I want you to have a general idea as to how we investigate a patient. Now, 2 basic rules that we need to follow. Investigating any patient for that matter. First, you're going to do non-invasive test, and only then will you go ahead and do a invasive test. So this is one dictum that we are going to follow. The reason why I'm going down to this basic is you'll see a lot of questions saying what is the next best line of management or what is the next step you're going to do. So if you understand these basic points, you'll be able to crack all the questions. Now, the other facet of investigations is the pattern in which you're supposed to go is first you're supposed to confirm the disease, okay, or confirm the diagnosis. The next set of investigation is to stage the disease. For example, let us take CA breast only as an example. Your first step is to do a mammogram and an FNAC and confirm that it is a malignancy, or mammogram and a core needle biopsy. Then you need to stage. You need to know whether the CA breast is still in the breast or has it gone to the lung, the bones, etc., so on and so forth. So then you need to do a CT scan or a PET scan. So that comes under staging. And the last one is the set of investigations that you need for treatment. That means if you are planning for surgery on this particular patient, so then you need to get a complete blood count, the renal function test, the liver function test, the PTA, PTT, INR, all these come under this. So please remember, this is the order that we're going to follow. Non-invasive first, followed by invasive. Then based on three other criteria, one is first you're going to confirm, next you're going to stage the disease, and next are the investigations needed for treatment. So now let's move on to how we evaluate a patient with a breast lump. Once a patient comes to you in the OPD, I'm sure all of us know, first thing you're going to do is the clinical assessment, where you're going to look at the lump, you're going to examine the lump, you're going to see whether it's a single lump, multiple lumps, multicentric, multifocal, then you're going to examine the axilla, then you're going to do radiological, and after that you're going to do the pathological assessment. Now I know this is a very basic question. Let's start with the basics and then get into the deeper aspects. Why do we do radiological first and then pathological? Can anyone answer? In short, why radiological first and then pathological? Why can't we do an FNAC first and then do the investigation? Why always radiological first? Does anyone know the answer? Even a short answer is quite okay for me. See, the idea behind doing this radiological test first, I'll give you a simple example. Let us say we have a patient with a CA breast of 4 centimeters. Now we know that that is T2 lesion. If I do a core needle biopsy or an FNAC or I'm doing some investigations, while doing the investigation, if I hit a blood vessel and I cause bleeding around the lump, and then I do a mammogram, that 4 centimeter lesion will start looking like a 6 centimeter lesion. Now this has become T3. So it will change the staging of the disease itself completely. It will change the staging completely. So that is the reason you always do a non-invasive first and then invasive. I hope you understand the dictum, whatever I spoke about. Now it's starting to make sense. So that's why first you're going to do radiological, then you're going to do the pathological assessment. Now let's look at the radiological assessment. Now what are the three radiological investigations that we have for diagnosing a breast disorder or a breast disease? The most common one that we use is your digital or your X-ray mammogram. We all know that it has a mediolateral oblique view and a craniocaudal view, two views. Now the idea behind the mammogram is we are going to flatten the breast so that all the fat gets dispersed, and then you're going to look at the parenchyma and the lesions. Correct? This is the idea behind doing a digital or a X-ray mammogram. Now why should we flatten the breast? Okay, it sounds very silly. Why do you have to flatten? Just like a CT scan, do X-ray. Why do you have to flatten it? Now the best analogy I can give you is, I'm sure all of you have had this pulpy grape juice. I hope anyone, those of you who are fond of having juices and all, the pulpy grape juice, or let us say a milkshake with a lot of chocolate chips in it. If I ask you how many pulps of those grapes or something is there in the juice when it's in a cup, it becomes very difficult for you to answer very accurately. But the same thing, if you pour that juice onto a plate and spread it out, you will be able to see those grapes much easier at that point of time. So that is the idea behind flattening the breast. So once you flatten the breast, all the fat gets dispersed and only the parenchyma and the lesion is left behind, and you can characterize it better. Now, why am I telling you all these basics? The idea behind telling you all these basics is, for mammogram to work, you need to have more fat and less parenchyma. Okay. Now, in which category of patients will we have more fat and less parenchyma? More fat and less parenchyma, is it seen in younger women or elderly women? Can anyone please answer in the chat box? Younger woman or elderly woman, where do we find more fat, less parenchyma? So this more fat and less parenchyma, this is seen in elderly women. Okay. Elderly women. Now, in elderly women, which of the following lesions are more common, benign or malignant? This is a pretty straightforward answer, malignant. So now, common sense says that if you have an elderly patient and you're suspecting a malignant lump, the first investigation that you want to do is a mammogram. Okay. You said younger. No, younger, you're going to have more parenchyma, less fat. Okay. In elderly, it's more fat and less parenchyma. Okay. So now that we have finished digital mammogram, now we know the indications of digital mammogram. Let's go on to sonomammogram. Sonomammogram is nothing special. It is basically ultrasound of the breast. Now, one of the main problems with ultrasound of the breast is that it is observer dependent. That means it depends on who's doing the ultrasound. For example, that is the difference between me cooking and my mother cooking. Both of us can cook, but at the end of the day, we all know the truth that my mother can cook better than me. Now, the reason why I'm giving you this example is, let us say we have a young girl with a lump and an inexperienced radiologist tries to do a sonomammogram for that patient, and they miss out on very important features like irregular margins or calcification, and they report it as fibroadenoma. Do you realize how much injustice is happening to that girl? Okay, I hope you understand the problem that can arise by using ultrasound to try and diagnose malignant cases. So, I told you that elderly patients, we are going to do mammogram. So, sonomammogram automatically will be done only in younger patients. And in younger patients also, I told you, you can't use it for high risk cases like wherever you're suspecting malignancy. So you only have to use it for benign conditions. So benign conditions means fibroadenoma, breast abscess, mastitis. These conditions you can use sonomammogram as the investigation of choice. So what does that leave us with? MR mammogram. Now this MR mammogram is one of the best investigations available. Now what is the only option left? Younger population with high risk. High risk means, let us say that girl or that female has history of family cancer, family breast cancers. That means either the mother or the sister, somebody has a breast cancer in the family. Now she becomes a high risk. There you can't take chance with a sonomammogram. These are patients who need an MRI mammogram. Okay. So I hope you have understood the indications of each of these investigations. They're very, very, very important. I've tried to be as slow as possible. So I hope this part is clear for you. So we'll just repeat it fast. Any elderly patient and you're suspecting a malignant lesion, the investigation of choice is a X-ray mammogram. In a young patient, if you're suspecting benign, that means there's no history of cancers in the family, nothing of that sort. It is a straightforward, mobile, firm lump. Then you can use sonomammogram. That means you're suspecting a benign lesion. Now, if it is a younger patient, but they have high risk of malignancy, that means either some BRCA mutation is there or there is family history of breast cancer, then the investigation of choice becomes a MRI mammogram. I hope this part is clear. Now, two more indications of MRI mammogram. This I'm pretty sure all of you know. Whenever there are implants, or if you're trying to differentiate between scar and recurrence. So these are two other indications of MRI mammogram. Now, a mammogram is reported as BIRADS. I'm sure all of you have seen this chart. I'm not going to go in through it. Now, all I want you guys to remember is this BIRADS 2 category. That means benign, because they'll give you features of a fibroadenoma and they'll say what BIRADS category does this belong to. So benign is 2. That is fibroadenoma is category 2 or BIRADS 2. And 4, this is something that I want you to know. This is suspicious of malignancy, because BIRADS 4 onwards needs tissue diagnosis. That means you need some sort of pathological assessment. Now, so far we spoke about diagnostic investigations. That means patient has come to you with a lump and then you're deciding what investigation you're going to do. Now there is another entity called as screening investigations. That means before the lump comes. That means you want to catch it at a very early stage, or you want to catch it even before it appears, or in high risk patients, like I told you, BRCA mutations, all those. So these investigations are called as screening investigations. So the same mammogram, if you do it to identify the lump before it comes, then you're going to call it as screening mammogram. So now what does the latest guidelines tell about this? What is the age group, or what are the indications for doing a screening mammogram? For general populations, you're going to start at 40 years of age. If there is family history of cancer, you're going to start at 35 years of age. And if there are genetic mutations, you're going to start at 25 years of age. That means BRCA mutation, anything of that sort is there, then you're going to start at 25 years of age. Now, as we are talking about this BRCA mutations, I also want you to know that there are certain indications for doing this BRCA testing. That is the genetic testing, whatever we do, there are certain indications. You can't go on doing it for everyone and anyone on earth. Now, these are the indications: CA breast before the age of 50, bilateral breast cancer, breast and ovarian cancer in the same individual, male breast cancer, family history, close male relative with a breast cancer, and close relative with a early onset cancer. Now, I want you to remember only two things. One is the number 50. Okay, either the same patient develops a cancer before 50 years of age, or a close relative develops a cancer before 50 years of age. Next, if it's a patient with a male breast cancer or a close relative with male breast cancer. Two things you have remembered. Now remember the number 2. Okay, bilateral breast cancer, that means both the breast have cancer, or family history of 2 or more entities, that means 2 people in the family should have breast cancer, or 2 cancers in the same patient, breast and ovary in the same patient. So 2 things, age 50 and male gender, and everywhere double, both the breasts, ovary and breast in the same patient, or 2 members in the same family having cancer. These are the indications. Now, the reason why I am telling you this is this was a question that was asked in INICET, where they gave you a history of a girl who had a family history of cancer in the mother and the sister, and they asked what is the next thing you're going to do for them, and the answer was genetic testing and screening. I hope this part is clear. Very, very important. Potential question from this chart is possible. Now, as we're talking about BRCA, you need to know the difference between BRCA1 and BRCA2. Now, how do you remember this? The easiest mnemonic I can give you is ladies first. If you're a gentleman, I am assuming I am a gentleman, and I always do that whenever I open the car door, or I ask my wife to sit first or something like that. So we always follow the principle of ladies first. So remember, female cancers are more common in BRCA1. So if ladies first mean, obviously the male has to come second. So male cancers are more common in BRCA2. Now ovaries are present in female or male? They are present in female. Okay. So if ovaries are present in female, again ovarian cancers are more common in BRCA1. So in male, which is the organ which is not there in female? Prostate gland. So prostate cancer, colon and pancreas cancers are more common in BRCA2. Now, one extra thing that I want you to remember, BRCA1 cancers have poor prognosis, BRCA2 cancers have slightly better prognosis. Regarding this basal and luminal, I'll talk to you about it in a little while. Again, this is a very, very important topic, so I'll talk about it separately. Now, another point that I want you to know, this is a potential question. There is something called as a risk assessment model. Like, this is something that you're going to predict what is the risk of breast cancer in a patient. Normally what we do is the Gale's risk assessment model. This is the most commonly used risk assessment model, and this is done for general population. Now there is a risk assessment model for patients with BRCA mutation, and that is called as a Couch or the Tyrer-Cuzick model. So these are 2 models. So please remember, they can ask you which of the following is used as a risk assessment model for BRCA mutation. It's either the Couch model or the Tyrer-Cuzick model. Now we have finished our radiological assessment, and we digressed a little bit and covered the genetic mutations also because we were in and around that area. Now let's move on to the next one, that is pathological assessment. This I'm sure all of you know. The first thing you're going to do is a core needle biopsy. This is the investigation of choice for a breast cancer, not FNAC, it is core needle biopsy. You need to know this. You're going to use a 14 gauge needle preferably. Now, why a core needle biopsy over FNAC? There are 3 points why we use a core needle. Because one, you can confirm the diagnosis. Next, you can differentiate between invasive and in situ cancer. And next, you can get hormonal receptor markers. Okay. So these are also called as immunohistochemistry markers. There are 4 markers that we are looking at. That is the ER, estrogen receptor, progesterone receptor, HER2 new, Ki67. Ki67. Okay. Now, if the lesion is very small and it becomes very difficult for you to do a core needle biopsy, another technique which is available is this vacuum assisted biopsy, and the gauge of the needle that is used is either an 8 or 11 gauge needle. Now, if you are doing an FNAC, then you're going to use either a 21 or a 22 gauge needle. I hope so far it's pretty clear for all of you. If you have any doubts, please put it up on the chat box, and whenever I get time, I will try and clear them as and when possible. Now, we have done our core needle biopsy. We have got a sample. We have done the IHC, and I told you that 4 markers that we are going to look at. One was the ER, one is PR, one is HER2/neu, one is Ki67. Now, this Ki67 is a proliferative index. So proliferative index means it will tell you how fast the cell is multiplying or how fast the cancer is growing. So now if a cancer is growing very fast, Ki67 is very high. Now if the cancer is growing very slow, Ki67 is very low. Okay. Now simple question to all of you. If this is an aggressive cancer, will the Ki67 be high or low? Is Ki67 high or low? Invariably the Ki67 will be high because it's an aggressive cancer. Okay, so remember that much. Ki67 is usually high in aggressive cancers. On the other hand, you need to know one more point about this HER2/neu receptor before we get into the classification. This HER2/neu is reported as 0, 1 plus, 2 plus, and 3 plus. Now this 0 and 1 is negative, 3 is positive, and 2 plus is equivocal. Equivocal. That means 2 plus can either be here or there. So there was again a question asked in INICET regarding this. They have done the IHC and HER2/neu has come back as 2 plus. What will you do next? Because now it is equivocal. It can either be this side or that side. So to confirm whether it is positive or negative, your next step is to do FISH, fluorescent in situ hybridization technique, and that will tell you whether it is positive or negative. Okay. So far I hope it's clear. Now let's get into this very, very important classification of CA breast based on gene expression. Okay. Now just remember one thing when we are clarifying this. Luminal A has the best prognosis. Now, if you have best prognosis, that means the cancer should grow slowly. So if cancer should grow slowly, Ki67 will be low or high. If cancer has to grow slow, Ki67 is low or high. Please keep commenting on the chat box. Ki67 should be low. Okay. So remember, only in luminal A, Ki67 will be low. Rest everywhere Ki67 will be high. Okay. Now let's look at the others. Now luminal A, ER will be positive, PR will be positive, HER2/neu will be negative. That means you can treat these patients with hormonal treatment. HER2/neu being negative is a good point. Now look at the other one, basal. Now basal has the worst prognosis. I'm telling you, it's the worst of the lot. Now, how do you remember the characteristic features of basal subtype of breast cancer? Basal means bottom, rock bottom. So when you are in the worst phase of your life, what is going to happen? Everything is negative. That means even the thoughts that occur to you are negative. Correct? So that time, when you're talking about basal cancers, remember everything is negative. Even your thoughts are negative. Remember it like that. Rock bottom, everything is negative. So basal subtype is also called as triple negative. It's also called as triple negative. So now let's look at luminal B. Luminal B is in between luminal A and basal. That means ER can either be positive or negative. PR can be positive or negative. HER2/neu will be negative. But the only thing is Ki67 will be high. Okay. So at least ER or PR should be positive, and if Ki67 is high, it becomes luminal B. If Ki67 is low, only one option, luminal A. If everything is negative, it is the basal subtype. One other subtype is your HER2/neu enriched. HER2/neu enriched. Now in HER2 new enriched, everything will be negative, only HER2 new will be positive. Okay, this is one more subtype. And the last one is claudin. This claudin is basically a subtype of your basal type of breast cancer. Everything will be negative, and along with Ki67, they will have claudin gene. They will have expression of a claudin gene. So I hope this part is clear for all of you. Very, very important, because they've asked 2 questions in the last 2 years, okay, on the same topic they've asked twice. So very, very important. I hope this part is clear for you. I will quickly repeat it for your benefit. Ki67 is low only in luminal A. Basal means rock bottom, that means everything is negative. In between is luminal B. HER2 new enriched means only HER2 new is positive, rest all is negative. Claudin is a variant of basal subtype where everything is negative and there is a presence of a claudin gene. Now let's move on to treatment. Now we have finished our investigations, we have done our diagnosis, we have our classification, staging, everything is ready. Now we have to treat the patient. Now to treat the patient, now they are categorized into 4 stages: stage 1, stage 2, stage 3 and stage 4. Stage 1 and 2 is called early breast cancer, stage 3 is locally advanced, and stage 4 is advanced breast cancer. Now why have they been divided like this? Now the idea is in stage 1 and stage 2, the tumor is still small, so they think that it is not yet spread anywhere. So first you operate and then you give chemo. That is the idea. First surgery, then you're going to give adjuvant treatment in the form of chemotherapy, radiotherapy or whatever is needed. Now if it's a locally advanced breast cancer, here what's going to happen, the tumor is already grown to such an extent or to such a size that it would have already spread, even though it is not obvious metastasis, but you will have little bit of cells going into the bloodstream here and there. So when this happens, you have to be extremely worried, because after surgery you again have to wait for 2 weeks before you give any sort of adjuvant treatment. So in between this duration only, those small cells can actually get deposited somewhere and end up becoming a cancer. Okay, so what they are saying is give chemotherapy first, that is called as neoadjuvant chemotherapy, and that is followed by surgery. Okay, so that is the reason you need to know the difference between locally advanced breast cancer and early breast cancer. Now staging is very easy to remember, but you need to know the TNM break or the cutoff, which you're going to call early, which you're going to call locally advanced. So for that, all you have to do is remember the mnemonic 3, 2, 1, 0. Okay, T2, N1, M0. That's all you need to remember. Okay, anything less than this, that means anything less than T2, N1, M0 is considered as stage 1 and 2. That means T1, N1, M0, T1, N0, M0, and the only thing left out is 3. So this is T3, N0, M0. So T3, N1 comes into locally advanced. That's the only thing that you need to remember. So for this 3, only exception is T3, N0, M0. So anything above this becomes stage 1 and 2. Anything below this becomes stage 3, where you're going to give neoadjuvant chemotherapy and then you're going to operate. Now first let's talk about the surgeries that we are going to do. First is the modified radical mastectomy, where we remove the entire breast and nipple areola complex and we do an axillary lymph node dissection. Now a simple question for you guys. Why do you have to remove the entire breast tissue? Why not only tumor, like how we do for skin cancers? Only one area we can remove. Why do we have to remove the entire breast? Now the idea behind this is that, please understand, even though the tumor has happened in one quadrant of the breast, okay, it's happened in one quadrant of the breast, the rest of the breast is still exposed to the same risk factors. Okay, there can be micrometastasis there. So that is the reason they were worried and they were removing the entire breast. Now what they said, you're only worried about micrometastasis, no? So we will handle the micrometastasis in some other way. Just do a small excision in and around the lump. That is called as a wide local excision. That is where this concept of breast conservative treatment came into picture. So what they did is, they did a breast conservation surgery, which is a wide local excision. Then they said whatever little micrometastasis is there in rest of the breast, we will give radiotherapy and kill them off. And then we will treat the axilla. Again, same concept. If axilla is inward, that means if a lymph node is positive, we will do axillary lymph node dissection. If the lymph node is not inward, and how will you know whether it is inward or not? You're going to do a sentinel lymph node biopsy. So if sentinel lymph node biopsy is positive, you will do a ALND. If it is negative, you will not do anything. So nothing is done if sentinel lymph node biopsy is negative. So this is the concept of breast conservation treatment. So what I'm trying to stress here is that BCS and radiotherapy go hand in hand. They cannot be done separately. Okay, radiotherapy is not an optional treatment. Radiotherapy has to be done compulsorily. Okay, so BCS and radiotherapy are part and parcel of breast conservation treatment. Now, a few more important points about BCS. What is the margin? You're going to have a 1 centimeter margin. Now, you're going to take that 1 centimeter margin, then you have to send it for testing. So what testing you're going to send? You're going to send it for frozen section. Okay, you're going to send it for frozen section. Now, how will the pathologist know which is the anterior border, which is the posterior border, superior, lateral, medial? Because he has to tell you, which border is involved, so that you can again go and revise your margin. So for that, you have to do labeling. Now, there is a code for that labeling. Let us say this is the lump I've removed and sent it to the pathologist. I put 2 stitches, one on the superior border and one on the lateral border. So remember, superior border short stitch, lateral border long stitch. Okay, superior border short stitch, lateral border long stitch. This is how we are going to label the specimen and send it to the pathologist. Then the pathologist will call and tell me, okay, superior margin is positive. Then I again go in and I revise the margin by another 1 centimeter, and hopefully that turns out to be negative. This is the idea. Now, if this margin becomes positive twice, that means in spite of resecting twice and the margin still continues to become positive, then I have to abandon my BCS and go ahead with a more definitive surgery, that is in the form of a modified radical mastectomy or a skin and nipple saving mastectomy. Now, the reason why I'm talking about the skin and nipples sparing mastectomy is that they can ask you questions as all of the following can be done except, or which of the following are treatment options, and they can give you 1, 2, 3, 4 and give you options 1 and 2, 1 and 3, 1 and 4, so on and so forth. So skin and nipples sparing or saving mastectomy can also be done. Now, the criteria for doing this is that the tumor or the lump should be more than 1 centimeter away from the skin and more than 2 centimeter away from the nipple areola complex. So these are the 2 indications for doing a nipple sparing mastectomy. Now you have removed the lump. Let us say this is the breast and I have done a wide local excision. Okay, after I have removed this, I need to close that gap. Now, how many of you have seen this ad where they have, or reels on Instagram where they have a big pizza and they take out one strip in between and they bring the 2 halves of the pizza together? It still looks like an entire pizza, correct? Same concept can be used in breast also. If a very small amount of breast tissue is taken out, you can just raise a little bit of flaps that side, this side, approximate it, and it will still look like a normal breast. So the cosmesis is maintained. Okay, so this is called as displacement. That means from adjacent areas I'm taking out and closing this. So this is called volume displacement. Okay, volume displacement. Now the criteria for doing volume displacement is that only 20% or lesser of the breast tissue must be taken out. So if it is less than 20% of breast tissue which is taken out, then you can do a volume displacement reconstruction, and this is called as level 1 oncoplasty. Very important point, please keep this in mind. This is called as level 1 oncoplasty. Now by chance, if you have taken out a bigger chunk of breast tissue, that means this is more than 20%. If you have taken out more than that, now if you try to bring it together, the breast will get crumpled up like this. Now the breast gets crumpled up, cosmesis goes for a toss. So now you can't, there's no idea of doing BCS. The whole idea of BCS was to get cosmesis, good cosmesis. So if cosmesis is lost, then there's no point of doing the surgery. So at this point, don't try to do volume displacement, instead do a replacement. That means replace that empty space with some other tissue. So here you're going to do like flaps or implants or autologous fat transplantation. All that can be done here. So the criteria for doing a volume replacement is if the loss of breast tissue is more than 20%, then you're going to do volume replacement, and this is called as level 2 oncoplasty. Level 1 oncoplasty, volume displacement; level 2 oncoplasty, volume replacement. If there are any doubts or questions, please put it up on the chat box, and as and when we get time, we will try and clarify them. I know we are going a bit in depth, but these are very, very important topics. Trust me, very, very important and potential questions. Okay, if there are any questions, please keep putting it up on the chat box. Now let's talk about contraindications of this breast conservation surgery. With respect to the primary lesion, if the tumor to breast ratio is very large, okay, there is no cutoff for the size of the tumor. Even a 4 centimeter tumor in a small breast is considered as a big lump. Okay, so it's always tumor to breast and not the size of the tumor alone. But the same 4 centimeter lump in a big pendulous breast, you can do BCS, but the same lump in a small breast, you can't do BCS. I hope you're understanding the difference. Very subtle difference. So it is a tumor to breast ratio. Of course, multicentric and multiple tumors, you can't do BCS. It doesn't make sense. And if you have positive margins twice, now this is called as a persistently positive margin. Okay, persistently positive margin, or a PPM. And at this point, you're going to abandon doing BCS and instead go ahead and do a modified radical mastectomy or a skin and nipple saving mastectomy. I hope this part is clear. Now, I told you radiotherapy is part and parcel of BCS. So if the patient is pregnant, you can't do your breast conservation surgery because you can't give radiotherapy. So pregnancy is a contraindication. If there is collagen vascular disease, or if there is history of previous irradiation to the chest, then you cannot subject these patients for breast conservation surgery. Now let's move on to the more conventional surgery which all of us are aware of, MRM. Here you're going to remove the breast, the nipple areola complex, and the axillary group of lymph nodes. Now in axillary group of lymph nodes, what all do you remove? You're going to remove level 1, level 2 and level 3. This is mentioned in Bailey and Love. Please remember, level 1, level 2 and level 3 group of lymph nodes are removed. There are 3 subtypes, that is the paties, the scanlons and the Auchincloss. Just remember paties. Okay, remember P pectoralis minor is removed. In the other two, it is retracted and split. In paties, pectoralis minor is removed. Okay, now after you have done your axillary dissection, you're going to put in a closed suction drain. Now for those of you who have not seen, this is how a closed suction drain looks like. You'll have a tube coming out like this. Now this has been asked as an image based question. Okay, what sort of a drain is this? This is a closed suction drain. Now because drain is a very important topic, they can ask you where are the areas where you routinely use a drain. Now the idea of putting a drain is to prevent one of the most common complications, that is seroma. Why will there be seroma in a patient who's undergone a modified radical mastectomy? That is because you would have disrupted all the lymphatics in the axilla. So when the lymphatics are disrupted, or when you remove the lymph nodes, the lymphatic channels are open now. Earlier they were draining into lymph node. You have taken off the lymph node, so there is only a channel there. So it will keep on oozing lymph. Okay. So wherever you have removed a group or chunk of lymph nodes, there is a high chance of developing seroma. These are areas where you are going to use a drain. Simple common sense. Where all do we do lymph node dissection? Very simple. Starting from up top. Neck dissection, that is a modified radical neck dissection. So drains, indication for drains. First is a modified radical neck dissection. Second, axilla lymph nodes we remove. So axillary lymph node dissection. Third, groin, we do a block dissection, no, carcinoma of the penis. So groin dissection, groin lymph node dissection. There also you have to routinely use a drain. Fourth, this is one exception, parotid surgeries, because the salivary gland is open, so they can have a sialocele, that means collection of saliva there. So to prevent that, you will use a drain in parotid surgeries. Okay, so these are where you'll routinely use drains in non-GI conditions. Okay, non-GI conditions. These are the 4 indications of using a drain. Now we spoke about surgeries. Now let's talk about the LABC, that is a locally advanced breast cancer. This is stage 3 breast cancer. Okay, stage 3 breast cancer. This is called as locally advanced breast cancer. And I told you here, you're going to first give chemo, then surgery. That is called as neoadjuvant chemotherapy. Now, how do you know your neoadjuvant chemotherapy is working for the patient? You really don't know, correct? You've given chemo and you're hoping that it works. Now, there is a criteria to find out whether the neoadjuvant chemotherapy has worked, and that is by the RECIST criteria, that is response evaluation criteria in solid tumors. Response evaluation criteria in solid tumors. So here it is categorized into 4. One is complete response, that means the tumor has completely shrunk. Next is a partial response, where there is less than or equal to, there is greater than 30% reduction in size. Stable disease means where there is less than 30% reduction in size. And progressive disease means there is actually an increase. That means your chemotherapy is making absolutely no impact and instead the disease is continuing to grow. Now the next question arises, when do you check for all this? After how many cycles of chemotherapy? The answer is 2 cycles. So give 2 cycles of neoadjuvant chemo, then assess whether the tumor is decreasing, whether it is same or whether it is increasing in size. Now if the patient falls into the first 2 categories, that is if there is complete response or a partial response, you will go ahead and do the, you're going to go ahead and finish the NACT. That means finish all the cycles of chemotherapy and then go ahead and operate. But if they're in the last 2 categories, that means if it's a stable disease or a progressive disease, that means your chemotherapy is not working. So there is no point continuing the chemotherapy. Abandon the chemotherapy, that is abandon the neoadjuvant after 2 cycles. Operate on these patients first. At least remove the tumor load. Operate and then give second line of chemotherapy. Okay, then you're going to give second line of chemotherapy. I hope this is clear. This can be asked. Okay, this is a potential MCQ. I hope this part is clear. Very, very simple. Give neoadjuvant. After 2 cycles, you're going to assess if it's in the first 2 categories. That means complete response or more than 30% reduction in size. You're going to finish your neoadjuvant chemo and then operate. If there is less than 30% reduction or more than 20% increase in size, then you're going to stop the chemo, operate, and then give further second line of chemotherapy, chemotherapeutic drugs. Now for stage 4, that means this is M1 disease or metastatic disease. This is usually palliative care. Palliative care. Okay. So here you're going to give hormonal palliative treatment, palliative chemotherapy, and there is a role for toilet mastectomy as well. This is only done for fungating growths, fungating breast cancers. Okay. So with this, we have completed all our conventional CA breast. Now let's move into certain important topics or certain points about CA breast in pregnancy. Few points that you need to note: that you cannot give chemotherapy in first trimester. You can't give radiotherapy in entire pregnancy, which means that you cannot do a breast conservation treatment. Surgery is the only option in pregnancy. But is there a role for BCS in pregnancy? Only once, that is in the 3rd trimester, where you operate and do BCS, and after delivery you will give radiotherapy. I hope this bit is clear. Okay, and if you're doing a central lymph node biopsy, you're going to use a low dose sulfur colloid. And remember, in chemotherapy, 5-fluorouracil is contraindicated. Something else that is contraindicated is your hormonal treatment. So even hormonal treatment is contraindicated in pregnancy. So they can ask this question as, which of the following are true with regards to CA breast in pregnancy? So all these are options that can be asked. Now, last thing that you need to know is regarding prognostic factors of CA breast. This is a question that has been asked. This is a table directly out of Bailey and Love. So all I want you guys to remember is there is something called as the Nottingham's prognostic index. Here 3 things are taken into consideration. Remember the mnemonic S and G, that is a solitary nodular goiter. That's how I remember it. Solitary nodular goiter. S is for size, N is for nodal status, and G is for grade. Now, if they ask you which among the three is most important, remember the one in the center is always the emperor or the king. Okay, the one in the center is always the most important. That's why you have seen in all podiums, the number one or the first prize is given to the person in the center. So remember, the most important prognostic factor is the nodal status. Now let's just talk a little bit about benign breast diseases. You need to know the full form of ANDI, that is aberration of normal development in involution. And with regards to this, there is something called as a evanescent lump. So what this means is, whenever there are hormonal changes, there will be some amount of breast congestion. So there can be a lump which the patient feels, and because of those changes in the hormones, once it settles down, the lump will vanish. Okay, the lump will vanish. That is why it is called as a evanescent lump. And this is a potential question, the Lucknow Cardiff scale. Now we know that patients can have nodularity on their breasts. Okay, now based on the Lucknow Cardiff scale, there are 5 classifications: 0, 1, 2, 3, and 4. You just need to know the name. They can put up this image and ask you what is the classification used. It is the Lucknow Cardiff scale. Little bit about mastalgia. We know mastalgia can be cyclical or non-cyclical. Cyclical means it keeps coming back the same time every month. It's a repetitive mastalgia. Okay, cyclical mastalgia. Now this is because of hormonal imbalances or hormonal changes. Now the first line of management of mastalgia is reassurance, breast supports, giving them NSAIDs and flaxseed oil. Now the role of this hormonal treatment is only if the VA score or the visual analog score is more than 3. Okay, if the VA is more than 3, only then you're going to give tamoxifen, danazole, LHRH agonist, and ormeloxifene. So remember, VA is more than 3, you're going to give these drugs. If it is less than 3, your first line of management is reassurance, breast support with good innerwear, NSAIDs, and flaxseed oil. Last point is regarding mastitis. Mastitis, the most common is lactational mastitis, that is a breast abscess. Okay, lactational mastitis, this is the most common. You have to know that USG guided aspiration is the treatment of choice, and avoid incision and drainage at any cost, because when you do this, there is a risk the patient will develop a milk fistula. And sometimes you can even go in and put in a suction drain, but the criteria for that is the size of the lump should be at least 3 centimeters, and you should have about 30 ml of pus on which you're going to identify on an ultrasound. Only then you can go in and put in a suction drain. So now let's solve a few questions from the PYQs. Okay, so I want you guys to answer in the chat box. Himanshu asks a question: is hormonal therapy used in early breast cancer? It can be used after surgery as an adjuvant treatment. So you have done surgery, then there are certain indications for chemotherapy. After that, you can give them hormonal therapy if they are ER/PR positive. I hope that answered your question. So this is the question: a 55-year-old female patient diagnosed with breast cancer. Which of the following is in accordance with the basal-like breast cancer? Please answer. Basal-like breast cancer. Basal means, I told you, rock bottom. Rock bottom means everything. Shabbir Lahari, excellent, excellent. Sakshi, good. So basal-like breast cancer means worst possible things. Rock bottom, everything will be negative. Everything will be negative. Excellent. Now next question: which of the following is not a contraindication for BCS? Which of the following is not a contraindication? Tumor size less than 4 with N1 maxillary status. Less than 4 means T2, N1, and of course we should assume it is M0. Okay, so let's look at the options from below upwards. Prior chest irradiation, isn't it a contraindication? It is a contraindication. We told you prior radiotherapy is a contraindication, so this can't be the answer. Multifocal tumors, we told you we can't do BCS. Tumor is larger than the breast. We definitely can't do BCS because you might as well do a mastectomy at that point of time. So the only option left is A. Excellent, Shabbir Lahiri. Excellent. Good, good. One more question. Which of the following are done in breast conservation surgery? Wide local excision, is it done? Yes. Axillary lymph node dissection, is it done? I told you axillary lymph node dissection or SLNB, both are part of breast conservation treatment or breast conservation surgery. So it is done. Frozen section, I told you yes. I even told you about the marking. So frozen section is done. Post-op radiation or radiation therapy is optional. Is it optional? No, it is not optional. It has to go hand in hand. I told you, because the micrometastases are there. So that is the reason why you're doing radiotherapy. Otherwise, you would have done a MRI. Okay. So this is not the right answer. So the answer will have to be 1, 2, and 3. 1, 2, and 3. That is option B. Option B. I hope you're understanding how we are solving these questions. I hope you're getting it. Now, which of the following is the most important prognostic factor in CA breast? What do I tell you? Nottingham's prognostic index. What is the mnemonic? Solitary, nodular, goiter. That is size, node, grade. And whichever one is the most important? Always the person in the center. Center, that means nodal status. Axillary lymph node status is the most important prognostic factor in CA breast. Okay. Any doubts or questions so far? Any doubts or questions? Any doubts? Good, Sakshi. Good. Good one, Apurva. Correct. A is the correct answer. Any doubts or questions? We'll just take a short break of about 10 seconds. I'll wait for your questions and then we'll go ahead. 10-15 seconds. Any questions before we go ahead to thyroid? Because breast is very, very important. I've been extremely slow. From now on, we'll speed up because these are all easy topics. But breast, I purposefully did it slow because I've covered a lot of topics which are not asked in the PYQs as well. Okay, any doubts? Please put it up. Done. If there are no doubts, can we move ahead to thyroid? Okay, of course, if there are some questions, keep putting it up in the chat box and we'll clear them as and when. So now let's speed up a little bit. So first thing in thyroid disorders you need to know is the anatomy. They'll ask you which is the major blood supply of the thyroid gland, and the answer is the inferior thyroid artery. Which artery supplies the parathyroid? That also the answer is inferior thyroid artery. This is a tricky one. Bruit is heard in which artery? Bruit is heard in superior thyroid artery. Now why is this? That is because you need to know the difference between superior thyroid artery and inferior thyroid artery. Now remember, superior thyroid artery is a single artery. Okay, it comes as single pedicle. Single pedicle. Whereas inferior thyroid artery, we all know it comes as branches because it supplies the parathyroid. It has multiple areas which needs to supply. So it comes as branches. It doesn't come as a single pedicle. So this comes as branches. So obviously whenever you have a single pedicle, more amount of blood flow will be there as compared to branches. So that is the reason you can hear bruit better in a superior thyroid artery. Second thing is in relation to the way the thyroid cartilage is positioned. If all of you can just lift your neck up like this, you feel that the thyroid cartilage is front. That is the reason you can see the Adam's apple all the way in the front. So this is how the thyroid cartilage is. Okay, like this, the Adam's apple is in front. So even the gland is sitting like this. So when the gland is sitting like this, the superior pole is superficial. Okay, superior thyroid artery and the superior pole is superficial, whereas the inferior thyroid artery is at a deeper plane because the angle is inclined. Okay, so I hope that is clear. Now this is a very, very important classification. This is called as the Cernia classification. Recurrent laryngeal nerve, everybody knows, everybody would have studied, but this is something most of you will not know. There is a classification for the way the superior laryngeal nerve is in relation to the superior pole of the thyroid. Now this is classified as type 1 and type 2. based on how far the nerve crosses the superior thyroid artery away from the superior pole. So from the superior pole, if the nerve crosses more than 1 centimeter away, the distance between the crossing and the pole, if it is more than 1 centimeter, you're going to call it as type 1. If it is less than 1 centimeter, you're going to call it as type 2. Now in type 2, we again have A and B. A means it is above the pole, B means it is below the pole. Now, why is this important? Olden days, I'm sure, or not even olden days, even in your postings, you would have learned from your seniors and all, or whoever they would have told you, whenever you're operating on thyroid, ligate the superior pole close to the gland and inferior pole away from the gland. Okay, this is what the old school of thought was. Earlier, that's what they used to do. Superior pole close to the gland, inferior pole away from the gland. They used to tie the artery and the blood vessels. Now, if you try to ligate close to the gland, there is a chance you can damage this superior laryngeal nerve. So, the maximum amount of damage happens in type 2A of Cernia classification. Remember, type 2A is where the nerve is most commonly injured. Now, few more tidbits about thyroid. There are certain special tests of examination. First is Pizillos. How do you remember Pizillos? P for palm. So take your two palms, interclasp your fingers, put it behind the occiput and push your neck against the palm, or your occiput, push it against the palm. So when you do this, there is lordosis of the neck. Okay, there's lordosis of the neck, and the thyroid and the entire component of the neck gets pushed forwards. So this is done when you normally can't see the goiter. Next is your Lahey's method. Okay, this has been asked, the Lahey's method. So how do you remember this? L for L. Lahey's means lateral. So what you're going to do here, you're going to push the thyroid gland laterally. Push it laterally and then feel for the posterolateral surface. Okay, feel for the posterolateral surface. If there are any nodules, that means is this a multinodular goiter? Next, you're going to look for Kreil's method. This is the only thing left out. Here you're going to do anterior surface. So keep a finger on the thyroid, ask them to swallow, you will feel tiny nodules running against your finger. So now this has been asked, Lahey's method has been asked. Okay, this is one of the questions that has been asked in INICET. So please keep it in mind, it's a very, very important topic. Yes, Brijay Singh, you're correct. Superior is close, inferior is away from the gland. That was the earlier teaching. Now the teaching is identify the nerves and tie. That's all. Okay, earlier was if you don't see the nerve, you wouldn't have damaged it. Now it is you should see the nerve and not damage it. You have to safeguard it. Okay, now coming to evaluation of a thyroid gland. I told you normally we do imaging first, that is non-invasive, then invasive, then blood test needed for treatment. In thyroid is one place where we beat that rule. Okay, here we do TSH first. I'll give you 10 seconds for this. Why do we do TSH first? Why can't we directly do ultrasound and FNAC? Can anyone answer? Why should we do TSH first before we go ahead? I'll keep talking as I wait for your answers. Now TSH can either be raised or it can be low. If it is low, that means it is hyperthyroid. If it is raised or normal, that means it is either hypo or euthyroid. Okay, subclinical hypothyroidism to see if they are in euthyroid state. Excellent answer, but I'll give you an easy way of remembering this. How many of you are in a relationship? Yes or no? How many of you are in a relationship? If you had a girlfriend or something, if you don't want to, okay, I think it's a very controversial topic to be asking you all these questions on YouTube because I will not disclose your identity. Don't worry. Okay. So if you are in a relationship and if you have either a girlfriend or a boyfriend, if they're very angry, what is the thing you're going to do? Are you going to irritate them and put a pin into them and irritate them more, or you're just going to let them be, or let them calm down and then find out what the problem is? Simple common sense is you're not going to needle them even further because they lose their mind, especially with a closed loud one. Okay, they will definitely lose their mind. I've gone through this. So, sometimes. Okay, so think about the same thing now. Please understand, in thyroid, even on ultrasound, you cannot differentiate between hyper and hypothyroidism. You can only do that with the help of TSH. So, if a patient is in hyperthyroidism state and you put a needle into the thyroid, you can trigger a thyroid storm. Okay, you can trigger a thyroid storm if you try to do an FNAC. So, that is the reason you should always know whether the patient is hyperthyroid or not. Okay, so never try to do any sort of tests before you get a TSH done. So now let's fast forward. In hyperthyroidism, I told you can't do FNAC. So what are you going to do? First thing you're going to do is you're going to do an ultrasound of the neck, USG neck. Now in USG neck, it will tell you whether it is a diffuse goiter or nodular goiter. Diffuse goiter means Graves' disease. Nodular goiter means multinodular goiter or a solitary nodule goiter. Now if it is a multinodular goiter, if it's a Graves' disease, first let's talk about Graves' disease. If it is Graves' disease, there are certain autoantibodies. So you will have to check for thyroid autoantibodies. Correct? Now if it's a multinodular goiter, which is in toxic state, you want to know whether all the nodules are equally involved or only one nodule is involved or the internodular tissue is involved in the hyperfunctioning. Correct? So you need to have this information. So this information you're going to get with a radioactive iodine scan or a thyroid uptake scan, whatever we want to call it. So these are the tests that you're going to do for a hyperthyroidism patient. You will not do FNAC. Whereas on the other hand, for patients who are hypothyroid or euthyroid, first scan or first investigation is always an ultrasound of the neck, and then certain patients will need an FNAC, and after that you will go ahead with the necessary treatment. I hope this part is clear. Now the ultrasound of the neck that we do, that is reported as TIRADS. Excuse me, yeah. So the ultrasound of the neck is reported as TIRADS. BIRADS in breast, TIRADS in thyroid. Now the components that you're going to look at is composition, echogenicity, shape, margin and echogenic foci. Now based on the scoring of all of this, you're going to report them as TIRADS 1, TIRADS 2, TIRADS 3, TIRADS 4, TIRADS 5. Now remember 3, 4, 5 are a criteria for FNAC. Okay, FNAC is done for TIRADS 3 onwards. So TIRADS 1 and 2 do not need an FNAC. They can ask you this question. They'll tell you ultrasound is done, TIRADS 1 is done. What will you do? Observe. If they say TIRADS 3, TIRADS 4, TIRADS 5, then you can go ahead and do an FNAC. So now the FNAC is reported as Thigh 1, Thigh 2, Thigh 3, Thigh 4 and Thigh 5. Okay. And again here, Thigh 3, Thigh 4, Thigh 5 is an indication for surgery. Okay. I hope you're getting the point. Ultrasound, TIRAD score, TIRADS 3, 4, 5, you do FNAC. In FNAC, Thigh 3, Thigh 4, Thigh 5, you're going to do surgery. I hope this part is clear. Now let's talk a little bit about radioactive iodine uptake scan, because they can give you the image of this radioactive iodine uptake scan and tell you what, and they can ask you what is the diagnosis. Now first one here is a simple and a normal thyroid gland. This is normal thyroid uptake. I want you guys to answer. I'm giving you the answer for A already. A is a normal thyroid gland. What is B, C, D and E? Whatever you know, please put up the answer. Very, very important question, image based questions. B, you can see there is equal uptake throughout the gland. That means there is diffuse uptake and it is an intense uptake. As compared to this, you can see here it's a bit gray, whereas here it is extremely dark. Okay, it's extremely dark. So this is Graves' disease because there is diffuse uptake. Now we look at the third one. There are nodules and multiple nodules have taken up the iodine. Multiple nodules have taken up the iodine. This is a multinodular goiter, or this is toxic MNG. You're going to call it as a toxic multinodular goiter. Correct Shabbir, correct Sneha. Graves B. Excellent, excellent. So C, I've already given you the answer, toxic multinodular goiter. Shabir, multinodular goiter, but you're supposed to say toxic multinodular goiter. What is D? D and E. Come on, guys. D, you can see that only one nodule has taken up intense amount of staining. Only one nodule. So this is a toxic nodule. Toxic solitary nodule. Toxic solitary nodule. And what is E? Where nothing is seen. Nothing is seen. E. When nothing is seen, E is, I'll give you the answer for now, thyroiditis. Now let me explain to you why in thyroiditis, even though there is hyperthyroidism initially, but there is no uptake on the thyroid scan. Sneha, you're correct. Reduced uptake. E. Hashimoto's. Yes, all these are thyroiditis. Now, for the benefit of others who don't know the answer, I'll tell you. In thyroiditis, the reason why you don't have a radioactive iodine uptake seen on the scan is that, so again, I go back to the same example. When somebody is angry, okay, when they're angry, they just want to vent out. They're not in a place to take any inputs. They just want to keep on shouting, fight without trying to understand anything. So now thyroid, when it is inflamed or angry, like there is thyroiditis because of inflammation, it gives out all the hormones. So when it gives out excess of hormones, it is not in a position to take up iodine, but it just wants to give out whatever it has. Patient will have hyperthyroidism. After a certain point of time, all the thyroxine which is inside the thyroid has come out. So that hyperthyroidism phase is over. Now there is no iodine inside because it was never in a position to take up the iodine. Now the patient will go in for hypothyroidism. Okay. Now because it is not taken up any iodine, on your iodine uptake scan, there will be no uptake. No uptake is seen only in thyroiditis. So initially they'll have hyperthyroidism, then eventually they will have hypothyroidism. I hope this part is clear and there are no confusions. If there are any doubts, please put it up on the chat box and I will try and clear them as and when. So there is a slight delay between me seeing your comments and going into the class. So whenever I see a question, whenever I can, I'll keep solving them. Okay. So now let's move on. What are the indications for surgery whenever you have a nodular goiter? Remember the mnemonic paracetamol, PCT. Okay. P is if the patient has pressure symptoms or if the patient wishes for the nodular goiter to come out. C, if there is suspicion of cancer or for cosmetic reasons if they want to undergo surgery. And on FNAC, I already told you, Thigh 3 to Thigh 5. All these are indications of surgery. Again, very, very important. They can ask you all of the following except, or they'll give you multiple options or multiple correct statements and they'll ask you which of these conditions are indication for surgery. Remember PCT, pressure symptoms, patient wishes, carcinoma suspicion, cosmesis, and Thigh 3 to Thigh 5. Now let's move on to surgeries. All you need to know, there are only two types of surgeries. One is hemithyroidectomy, where half the gland and isthmus is taken out. Okay. Next is total thyroidectomy, where the entire gland is taken out. There is something called subtotal thyroidectomy, where a certain amount of tissue is left behind. Can anyone tell me how much thyroid is left behind in subtotal thyroidectomy? Subtotal thyroidectomy, how much tissue is left behind? Meanwhile, I will tell you about this Hartley-Dunhill procedure. In Hartley-Dunhill procedure, one side you are going to do a complete hemithyroidectomy, and on the other side you will leave a small chunk of thyroid tissue behind and remove this part. Okay, this part is removed, this part is removed, only a small chunk in between is left behind. So this is called as Hartley-Dunhill procedure. Himanshu Sharma 8, Sneha correct 5 to 8, it is 8, Vikas Jadhav 5, it is 8. Okay, anyway, good try. How to remember this? Look at this S. Doesn't it look like 8 if I draw this line? Very simple, no? That's all surgery is. I keep teaching you all jugards like this, okay? This is how, because that's how I learned. I hope this is helping you. Subtotal, remember 8. Near total means remember half of it. So 4, okay? Subtotal means 8 grams. So this is all theoretical importance. They might not ask you, but I'll tell you why all this was done. Now the idea behind the subtotal was they would leave a small amount of tissue near the tracheoesophageal groove, wherever the recurrent laryngeal nerve and the parathyroids were, because they worried that time when they were operating, nowadays we have all cautery, bipolar, harmonic and all. Earlier days these were not there. So if a small bleeding happened, they could not identify the recurrent laryngeal nerve. So sometimes in their enthusiasm, they could have damaged the recurrent laryngeal nerve. So to prevent that, they would start leaving behind little sliver of tissue there to make sure that they don't damage the thyroid gland. This was the actual intention. The add-on to that was, if little thyroid is remaining, some amount of thyroid hormones will be produced. So the patient will not be in thyroid failure. We just have to give a little bit of supplement to it. So that was the idea behind this subtotal and near total thyroidectomy. I hope this part is clear, but for you guys, only remember hemi and total. Hartley Dunhill, they can ask as an MCQ, but I doubt it. So now our favorite topic, I told you, needling somebody when they're angry, thyroid storm. They'll ask you which is the most common cause. The most common cause is inadequate preparation prior to surgery. Now, if a patient is in thyroid storm, they'll have dehydration, hyperpyrexia, restlessness, and arrhythmias. The reason why I'm talking to you about these features is because you need to know the treatment. If you know the features, you'll know how to treat them. You're going to give them IV fluids, ice packs, steroids, anti-arrhythmic drugs, antipyretics. Antipyretics means paracetamol. It is also called as acetaminophen. Diuretics, IV propranolol, antithyroid drugs, and Lugol's iodine. So this question was asked in INICET, where they asked which of the following is not given in management of a thyroid storm. And the answer there was aspirin. You can see aspirin is not used in the management of thyroid storm. Okay, so the answer is aspirin for that particular question. Now, so far we learnt how the thyroid storm can occur because of inadequate preparation. So how do you prepare them for surgery? You're going to give them antithyroid drugs, and the most commonly used or the treatment of choice amongst the antithyroid drugs is carbimazole. This you have to give even the evening prior to surgery, up to evening prior to surgery. Propranolol you're going to give if the patient has tachycardia. Okay, if the heart rate is high, then you're going to give propranolol. This you're going to give even on the morning of surgery. Morning of surgery. And then you're going to give Lugol's iodine 7 to 10 days prior to surgery. Prior to surgery. Now, I will give you a simple way of understanding how this Lugol's iodine works. There are nodules and there are blood vessels in between the nodules. So how this Lugol's iodine works? It's very confusing. No, if you give iodine, ideally the function should increase. But why is it actually decreasing? Does anyone know the answer? Why Lugol's iodine decreases the functioning, or why it is used in preparation or prevention of a thyroid storm? I will anyway give you the answer because you're slightly running behind time. So just imagine you're hungry and somebody stuffs so much food in your mouth, okay, like all rotis, rumali roti, naan, garlic naan, butter naan, whatever you can think of. If they stuff it in your mouth without you being able to chew also, what will happen? Your mouth will become big. Wolff-Chaikoff effect. Excellent. I'm just telling that in layman terms. In layman or students like me who try to comprehend it this way. If your mouth is full with food and you're unable to chew, it is jam-packed. You can't chew. You have the iodine in mouth, but you're unable to utilize it. That is what is happening to the nodules. So look at this. The nodule is here. I give it iodine. So what will happen? The nodules will increase in size and they will become firm. So what is happening to this blood vessel in between? Blood vessel gets compressed in between these enlarged nodules. So when this happens, what will happen to the vascularity of the gland? Vascularity reduces. So Lugol's iodine will help reduce bleeding during surgery because it compresses on the vascularity. Okay. The action is the Wolff-Chaikoff effect. This is excellent. When you give something in excess, it tends to decrease the functioning of that particular organ. That is what the Wolff-Chaikoff effect is. But in simpler terms, this is how it is. Nodule enlarges. The blood vessels which are running in between the nodules will get compressed. and that will help reduce the intraoperative bleeding. Last thing we are going to discuss in thyroid is the MEN syndrome. This is the table, okay, where I've put up all the details here. 100% nobody will remember, including me. Don't worry, including me. How many of you have confusion in this MEN syndrome? How many of you keep getting confused between the features of MEN 1, MEN 2, MEN 3? MEN 3 is again MEN 2B. A thumbs up or yes or no, so that I know that my style of teaching will probably help you, because this is how I have been trying to learn. Okay, how many of you find it difficulty to remember the features of MEN syndrome? Jaldi. If you're finding it difficult, please put a thumbs up or say yes, and we'll go ahead. Either we will go ahead. I'm assuming it is a yes. Plus there's a bit of a delay. I might see your messages a bit later. Okay. So how do you remember this MEN syndrome? The easiest way to remember is by writing these alphabets up front. P, P, P. Okay. And keep replacing the last P with an M. Okay. So then you will get P, P and M. And the last one will become P, M, M. So I told you replace the last P with an M again. Okay. So this is the basic. Shabbir, Sakshi, then you will enjoy this. Trust me. Himanshu, even you will enjoy this. Okay. So PPP, PPM, PMM. Okay. Just write this quickly on a side of the paper and you will get the answer. Now how to remember the 3 P's? Because there are 4 P's. No? There is pituitary, there is parathyroid, pancreas and pheochromocytoma. How to remember the 3 P's? Best is go midline. All the midline structures. Pituitary adenoma. Okay. Pituitary adenoma. Next come here. Parathyroid hyperplasia. Again lower down in the abdomen. Pancreas is more or less midline only. Okay, it doesn't come to one side. It is more or less midline. Pancreatic neuroendocrine tumors. Pancreatic NETs, that is neuroendocrine tumors. So these are features of MEN 1 syndrome. Okay, MEN 1 syndrome. So just take the center one and push it down. Parathyroid hyperplasia will come down. That's all you need to remember. Parathyroid hyperplasia will come down into the MEN 2, okay, or MEN 2A. Now, what is the only P which is left out? Pheochromocytoma. Okay, because it is lateral. Because it's on top of the 2 kidneys, it is lateral. So, pheochromocytoma is lateral. Put it off into MEN 2. Okay, pheochromocytoma. And the rest becomes easy because we know M stands for medullary cancer of the thyroid. And again here, pheochromocytoma will continue. Medullary cancer of the thyroid will continue, and here you are going to get marfanoid features, mucosal neuromas. I hope this has helped. I'm already getting a lot of thumbs up. Okay, this is how I've been learning them, and I hope it's helpful for you guys as well. Okay, so now let's solve a few questions. I've not discussed this, but I want you guys to answer. Inferior thyroid artery supplies which of the following structures? Esophagus, thyroid, parathyroid and thymus. Okay, we know for a fact thyroid and parathyroid are supplied by the inferior thyroid artery. I already covered this. The upper end of esophagus is supplied by the inferior thyroid artery. Fortunately or unfortunately, even the thymus is supplied by the inferior thyroid artery. So the answer here becomes 1, 2, 3 and 4. All the 4 structures mentioned here are supplied by the inferior thyroid artery. Now let's look at this question. A woman comes to the OPD with palpitation, heat intolerance and weight loss. That means the patient has hyperthyroidism. Diffuse thyroid enlargement and exophthalmosis. That means this is Graves' disease. Which of the following investigation would you order in such a patient? Okay, which of the following will you do? Let's look at one by one. I already told you we are going to do ultrasound of the neck. Thyroid function test I told you is the first thing you're going to do. Will you do an FNAC? No, you will not do an FNAC, and I've told you why. Thyroid antibodies, that also I told you we are going to do. Iodine uptake scan also we are going to do. So the answer here is 1, 2, 4 and 5. Excellent, excellent, Sneha, excellent, Shabir. Good job. Okay. So I hope whatever you have learned so far, you're able to utilize them well. Now, a 40-year-old female patient is diagnosed with Graves. She is posted for surgery. Which of the following drugs will reduce the intraoperative bleeding? Intraoperative bleeding. I told you, very straightforward, very easy. The only thing I forgot to mention, I'd actually written it there, but I think I skipped it in that excitement of teaching you, is that Lugol's iodine is also potassium iodide. Okay, the content of Lugol's iodine is potassium iodide. So the answer here is potassium iodide. Lugol's iodine is the one which reduces the intraoperative bleeding by increasing the size of the nodule, and the blood vessels get compressed. Okay, done. So with that, we have covered thyroid. Now let's cover short topics. Within 10 minutes, we'll cover this, burns and all. 10-15 minutes, we'll just cover and brush it off to one side. So in burns, first thing you need to know is the layers of skin. Okay, this is pretty straightforward. Apurva correct, Shabir correct, KK correct. Excellent, all of you, excellent. Okay, so what are the degrees of burns? For that, you need to know the classification, or sorry, you need to know the various layers of skin. You will have epidermis, papillary dermis, reticular dermis, subcutaneous tissue, and muscle. Okay, now if epidermis is involved, you're going to call this first degree burn. Papillary dermis, you're going to call this second degree superficial. Reticular dermis, you're going to call this second degree deep. Subcutaneous tissue, you're going to call it as third degree burns. Muscle, you're going to call it as fourth degree burns. Now you need to know the features of these burns. So for that, all you have to do is draw a line between the top two and the bottom three. That means between second degree superficial and second degree deep, draw a line. Where is P present? Can you see P anywhere here? In any of these places, can you see the letter P? It is not there. P is only found here, papillary, P and P. So remember, P for pain. Wherever there is P, there is pain. So remember, first degree burn, second degree superficial burn are painful. So if this is painful, automatically these three will become painless. Okay. In second degree deep, sometimes you might have little bit of pinprick sensation, but more or less there is a lot of anesthesia already happening there, because the nerves which are running here would have got burnt. Next, look at where S is. Subcutaneous tissue and muscle. Forget about dermis. Forget about dermis there. Okay, all this dermis S you leave. But S subcutaneous tissue. S in muscle. So wherever S is there, scar. So the deeper burns, that is second degree deep, third degree, fourth degree, they heal with a scar. So automatically, what does that mean? First and second degree superficial heal without a scar. That means they only heal by epithelialization. Primary intention of healing happens here. Okay, primary intention healing here, secondary intention healing happens. So that is the reason why you're going to have a scar. Okay, hope this part is clear. One more thing that I want you to know: blisters. Blisters is seen in which degree burn? Someone in the chat box, jaldi, we are running out of time. We still have a lot of topics to cover. I want you guys to be a bit more proactive. Blisters are seen in which degree burn? 1, 2, 3, 4. There must be a delay, but anyway, I will go ahead. I'm assuming you guys are proactive and answering, and hopefully I can see them in some time. Okay. Remember B. B is second letter of the alphabet. One more jugaad coming your way. Second letter of the alphabet. That means second degree burns have blisters. Sneha, second degree deep. No, even second degree superficial can also. Just remember second. B is second letter of alphabet. So second degree burns will have blister. Now the question arises, how do you differentiate second degree superficial and second degree deep if both have blisters? One extra point is blanching. Please remember, there will be blood vessels in this area. So in second degree deep burns, these blood vessels will get coagulated. So if they get coagulated, when you press, there will be no blanching. Okay. So in second degree deep, no blanching. Whereas in second degree superficial, there will be blanching. So blisters, blanching, second degree superficial. Blisters, no blanching, second degree deep. And apart from that, what I tell you, very painful means superficial. If they heal without a scar, superficial. No pain, deep. If they heal with a scar, deep. Okay. So I hope this bit is easy for you. Now in Bailey and Love, they have come up with a chart. Okay. Very simple. They have come up with a chart. It looks very complex, but I'll make it very simple for you. So what they've done is they have called it as the two burn depth concept. That means they have also drawn a line and said above this one group they have done, below that one group they have done, with a little bit of addition to our conventional learning, whatever we learnt. So forget about what is written here. Just remember the chart. They've asked this. Okay. Epidermal is primary or the first degree burn. Superficial dermal means second degree superficial. Deep dermal means second degree deep. Full thickness means third or fourth degree burn. One additional thing that they've added is something called a second mid-dermal burn. So this is in between superficial and deep. So in between superficial and deep, in second degree only, they've made it three categories: superficial, mid-dermal, deep dermal. Okay, that is what they've done in Bailey and Love. So these three they have put into one category. These three they have put into another category. Now I already told you that first and second degree superficial, they heal without a scar. Okay, no scar. Whereas second degree deep, third and fourth, they heal with a scar. So this is the simple concept. If there is no scar, that means they are healing by epithelialization. All you have to do is conservatively manage. Just put dressings on it. Don't do anything else, because there is no scarring. No, so it look very good. Why do you want to unnecessarily make a cut and try to do anything? That is all the idea is. So all this first half, okay, the superficial burns, you're going to conservatively manage. Conservative management with the help of dressings. Whereas in the second half, where there is scarring, the idea is whenever there is scarring, there is secondary intention. There will be granulation tissue, there will be fibrosis, there will be scar contracture. All these complications can happen in the future. So that is the reason they say don't allow it to get to such an extent. Don't allow it to get to scar contracture and all. So what they suggest is do early surgical excision. That means don't allow the granulation tissue to settle in. Do an early surgical excision of the burnt area and do skin grafting. Do skin grafting. That's all. That is the idea. That is the idea behind this two burn depth theory. Okay. This is the concept, and the answer is very simple. If they ask you what is the treatment of second mid-dermal, just to confuse you, they'll put mid-dermal. Don't get confused. Dressings. Beyond that, early surgical excision with skin grafting, so that you are halting that secondary intention healing and putting a skin graft in order to minimize the chance of all those contractures and all that are happening. Excellent answer, Sneha. Good one. Now let's move on to assessment of burns. Which is the most common way of assessing burns? This is where a lot of us get confused. I've made this very, very easy. Okay, even I amazed myself when I actually came up with this. Which is the most common way of assessing burns? Wallace rule of 9. Jugaad alert. One more Jugaad coming up. I hope all of you are ready for one more Jugaad now. Okay, the most common is Wallace rule of 9. How to calculate this is you need to know where to put 9. So all I am telling you to do is draw one stick figure like this. Draw W over that person, like how I have drawn the W here. Can you see this W? The same thing, draw it on the patient like this W. Okay, and then at the level of the hip, draw a horizontal line, and next to every single stroke, write 9. Every single stroke, write 9. And head and neck, we are going to give 9. Okay, that's all. W and write 9 next to every single stroke. Now look at the magic of this. Entire upper limb, only one line is there. That means entire upper limb is this. I think we're back on. Lydia, good evening, good evening. Okay. So we're back on live. Good. Is my screen visible? Please, Jaldi, just Say yes, no, something. Is the screen visible? Screen is back on. Yes, Himanshu, excellent, thank you. All right. So like I was saying, wherever there is one stroke, 9, wherever there are two strokes, it is 18. Now look at this area. This area, there are 4 lines. 4 lines. 1, 2, 3 and 4. So 4 lines means chest, abdomen, upper back, lower back, all put together 4 lines. So give one line for everything. Front of chest 9%, abdomen 9%, upper back 9%, lower back 9%. I hope this is easy. Okay, because they will ask a question on this. AIMS, they have asked this twice. They have asked you to calculate the percentage of burns. So all you have to draw is a W and you will get them spot on. There is no confusion at all if you get this. And 9 for head and neck. Okay, any doubts so far? Any doubts? So I told you Wallace is for most common. Okay, but the best way of assessing burns is the London Broder chart. Again, one more jugaad, one more mnemonic coming in the way, B. Okay, thanks for making it so easy. Thank you so much. Okay, Broder's is best for burns. Remember this mnemonic, Broder is best for burns. So London Broder chart, it has the most accurate way of assessing burns. Okay, most accurate way of assessing burns is with the Lund and Broder chart. Now you need to know how we are going to resuscitate the patient. Here we are going to use the ATLS protocol. This table is directly from the ATLS manual 10th edition. Okay, you're going to use 2 into kg into body surface area. If you can't see it, I'll just write it here. 2 into kg, that is, sorry, the weight in kg into the body surface area, percentage burnt, and whatever you're going to get, let us say x. Half of x, that is x by 2, is given in the first 8 hours. And the other half, x by 2, is given in the next 16 hours. So whatever you calculate is for 24 hours. Half of it you're going to give in first 8. Next you're going to give it in the next 16 hours. And the target urine output is 0.5 ml. But in electrical burns, we are going to give double that fluid. That is 4 into kg into body surface area. Instead of 2, we are going to make it 4. And even our target urine output is going to be more. Here they are saying it should be 1 to 1.5 ml. Okay, 1 to 1.5 ml. They are increasing the target urine output. Can anyone tell me why? Sneha, 4 is correct, but why? Why are we giving more fluid in electrical burns, but in regular burns we're not giving so much? What is the difference between an electrical burn and a regular burn? Anyone? Why in electrical burns you have to give more fluid? Because loss of fluid in electrical burns is more. No. See, please understand, in electrical burns, we know that, excellent Himanshu, myolysis. So when the muscle is involved, whenever you're having electrical burns, because it traverses throughout the body. So when muscle is injured, it's going to give out myoglobin. Okay. So when myoglobin comes out, correct Sneha, the myoglobin will go and sit in the kidney. Okay, it will sit in the kidney and this can cause kidney failure. So the idea is you keep on giving more and more fluid, keep on flushing the kidney, make sure the myoglobin doesn't sit there for a long period of time. That is why the fluid that you're going to give is doubled, and the urine output you're looking for is also doubled. That is 1 to 1.5 ml per kg per hour. Okay, so please keep it in mind, very important. Electrical injury, it is 4, regular burns, it is 2. Okay, colloids you're going to give only after the first 12 hours. Why I've covered all this in the app, and I don't want to come here because we'll just get digressed. Okay, now let's solve 1 or 2 MCQs. 23-year-old male sustained burns, bursting of stove. Look at this, singeing of hair in the face. Okay, that means head and neck is involved, 9%. Then they've gone on to say front part of the chest. Front part of the chest is how much? I told you, no, if you're drawing 4 lines here, front of chest 9, abdomen 9, upper back 9, lower back 9. So front of chest means 9%. Then they have said front of both upper limbs. Be very careful. This is the triggering point there. Front of both upper limbs. Entire upper limb is 9%, front and back. So front of upper limb means half of it. So one upper limb front is 4.5%. The other upper limb front is 4.5%. And then they have asked us to calculate the total percentage of burns involved. So in this scenario, it becomes 9 plus 9 plus 4.5 plus 4.5, that is 18%. This is the answer, 18%. Okay, should be pretty easy and straightforward. Can you please repeat? I will do that. Okay. I didn't understand. What do you want me to repeat? I am assuming it's the electrical injuries. The electrical injury part. Correct, Shabir, correct. In electrical injuries, there is rhabdomyolysis. So the myoglobin goes and sits in the kidney and it can cause kidney failure. So you need to keep on flushing the kidney to make sure they don't go into AKI or they don't end up in dialysis. So that's the reason you're going to give more fluid, and even your target urine output should be more. I hope that is clear, Akshata. I hope that is clear for you. Okay. Now one more question. Industrial worker sustained burns to anterior aspect of chest and abdomen. So I told you chest 9, abdomen 9, because we are given 4 lines, right? So 2 to the front, 2 to the back. So in 2 front means chest and abdomen 9 and 9. So 9 and 9. Then they said right upper limb. Right upper limb. Here they have not specified front or back. So we are going to assume it is complete. So right upper limb 9%. And then they have said front and back of right thigh. Front and back. So I told you front of thigh is 4.5%. Back of thigh is also 4.5%, because entire lower limb is 18%, correct? So full front of lower limb is 9. If they tell only thigh means 4.5. Full back of lower limb is 9%. So if they say back of thigh, it is 4.5. So 4.5 plus 4.5 is 9. So you have 1, 2, 3, 4. 4 9s are 36. 36. Okay. So I hope that part is clear for you guys. 36. Okay. Good. So we have covered burns. Any doubts or questions so far? We are going to get into a very, very, very important and elaborate topic now. Hepatobiliary disorders, gallbladder disorders. Are you all ready for this? This can tickle your brain. It's a bit elaborate. I know it's a bit difficult for the UG students, but I want you guys to concentrate. I know the IPL match has started. If someone can be, please be kind enough and put up the score on the chat, it'll help me as well. Okay. So hepatobiliary disorders, please stick with me. Next half an hour, 45 minutes. I know it's a very difficult topic. Please stick with me. I'm only going to discuss the high yield points, very, very high yield points, because you had 8 questions in the last INICET, 8 questions. Okay. It's a tough topic, but I want you to stick with me for the next half an hour, 45 minutes. Okay. Good evening, Meenakshi sir. Good evening. Good evening. Thank you. Thank you for your lovely words. So we know that hepatobiliary disorders are known for anatomical variations. Okay. In that, one of the important anatomical variation is what we call as a Moynihan's hump. Normally in this cystohepatic triangle, we only expect the cystic artery. So instead of the cystic artery, sometimes the right hepatic artery will take a tortuous turn like this. Okay. So Moynihan's hump is nothing but a tortuous right hepatic artery. Thank you, Dr. Meenakshi. Thank you for that. Okay. So it's a tortuous right hepatic artery. So normally some people might get confused that this only is the cystic artery. They'll either end up clipping and cutting it or damaging it and causing torrential bleeding. That is the reason this is very dangerous. Okay. It's very, very dangerous. So that is something that you need to keep an eye out for. Moynihan's hump. It's also called as, it is nothing but a tortuous right hepatic artery. It's also called as a caterpillar turn of the artery. Caterpillar. If you've seen how a caterpillar works, okay, walks like this, it keeps going flat, then pulls itself. So it keeps going flat, pulls itself. So that is why it's called as a caterpillar turn. The next anatomical variant, this was asked, please note, this was asked, this is a Phrygian cap. So basically there's a place in Turkey. So there is a place in Turkey called as Phrygia. Okay, Phrygia, sorry, dyslexia, sorry. So there is a place in Turkey called as Phrygia. Okay, that is where they used to wear this caps. So that is what it is. Okay, this is called as a Phrygian cap. So if the fundus of the gallbladder is in that shape, you're going to call it as a Phrygian cap. Next we move on to gallstones. There are 3 types: cholesterol, pigment and mixed stones. Cholesterol stones are the most common. Majority of them are radiolucent. 80 to 90%, which means that these are not picked up either on X-ray or CT. So what this implies is that ultrasound of the abdomen is the investigation of choice. But if they ask you gold standard, then the answer becomes MRCP. Okay, MRCP. Okay, done. So next, let's talk about acute cholecystitis. So normally what happens, your gallstone which is sitting in the gallbladder here, if it goes and gets stuck in the neck of the gallbladder, the patient will have pain because the gallbladder is trying to contract against a closed opening. So the patient gets pain. If the stone falls back to its original position, the pain goes away, and this condition is called as a biliary colic. This condition is called as a biliary colic. Okay. Now, the problem with this is that it might fall back, it might not fall back. If it doesn't fall back, then it goes on to become acute cholecystitis, because what will happen is you will have little bit of distension of the gallbladder. Like this, the gallbladder will get distended because the opening is blocked. There will be some amount of infective fluid which comes and surrounds the gallbladder. Okay, this is called as pericholecystic fluid, and this is the initial stage of acute cholecystitis. Now here comes a very, very important point or topic. This is again a table from Bailey and Love. This is directly taken from Bailey. Okay, so what they say here is there is something called as Tokyo consensus. We are all very familiar with Tokyo consensus for severity. I'll come to that point, but there is also something called as Tokyo consensus for diagnostic. Okay, diagnosis of acute cholecystitis, diagnostic accuracy or diagnosis of acute cholecystitis, where we are going to take in three things into consideration. One is local signs of inflammation such as Murphy's sign or right upper quadrant tenderness or mass. I want someone to answer what is the difference between Murphy's sign and right upper quadrant tenderness. Okay, answer and I will get to that. Why biliary colic is not a true colic? Because colic is basically intestine which is compressing and it's a pain which is colicky. Biliary colic is actually a continuous sort of pain. It is not a colicky pain. It is a continuous pain which is there for some time, and as soon as the stone falls back, the pain goes away. It is intermittent, but the duration of pain when it is there, it is a continuous sort of pain. That is why it is a biliary colic and not a true colic. Okay. So coming back to this, you're going to have local signs of inflammation, Murphy's sign or right upper quadrant pain, systemic signs of inflammation. I told you some amount of infective fluid is around the gallbladder, so the patient can have fever, elevated CRP or a raised total count. And then third thing, you're going to look for imaging findings. So if you have one in each of these category A, B and C, then it becomes a definite diagnosis. But if you have only A and B, then it becomes a suspected diagnosis. So in short, what I'm trying to tell you is C, imaging finding means I told you ultrasound. So only ultrasound is definitely diagnostic of acute cholecystitis. Rest all is only suspected. If ultrasound findings are there, then it becomes definite diagnosis. So what are the things we are going to see in ultrasound? Wall thickness, pericholecystic fluid and a USG Murphy's sign. Basically whatever we are going to do here on regular palpation, we will do it with the ultrasound probe as well, and that is called as a USG or a radiological Murphy's sign. Now this is applicable for acute cholecystitis. So stone is here, that is okay. By chance if the stone slips down and gets stuck in the lower end of CBD, okay, now you have a stone in the lower end of CBD, what is going to happen? The CBD is going to get dilated. Okay, if gallbladder can dilate, even CBD can dilate, because again now also there is a blocked opening. The intrahepatic biliary radicals will get dilated like this. Okay, intrahepatic biliary radicals are dilated. So these are all indirect predictors of a stone in the CBD. So if there is a stone in the lower end of CBD, you're going to have obstructive jaundice. So what are the features you're going to see on an LFT? Raised total bilirubin, raised direct bilirubin, raised alkaline phosphatase and a raised gamma glutamyl transferase. All these are features. So please note what I'm trying to tell you is whenever patient has a dilated CBD or dilated intrahepatic biliary radicals or abnormal LFT, you should suspect that a stone is in the lower end of CBD. Now remember, the lower end of CBD is not very well seen on an ultrasound because it gets hidden inside the loop of the intestine, between the C loop. And whenever there is air inside the intestine, it becomes very difficult to identify anything with the help of an ultrasound. That is where MRCP comes into picture. So in short, what are the indications of MRCP? Dilated CBD, dilated IHBR, or a deranged LFT. So these are the indications for doing a MRCP. Okay. Murphy sign, I'll get to it. I want you guys to answer. Then I'll give you the correct answer. Okay. So I hope that part is clear. When we are going to do MRCP, I've already told you. Okay. Now let's move on to how to know the severity of acute cholecystitis. How to remember this. This is very important because it also makes a difference in the treatment. So I told you in acute cholecystitis, stone is stuck. First thing that will happen is gallbladder will get distended. Okay. Why will gallbladder get distended? Because it has to secrete something. So what is it going to secrete? What is it going to secrete? Gallbladder is going to secrete mucus. Okay. Now, if mucus is inside a cavity, then you're going to call it as mucocele. So first stage is biliary colic, acute cholecystitis, and still the stone doesn't get relieved, then you're going to call it mucocele. And if that mucus gets infected and gets filled with pus, what are you going to call it? Empyema. Empyema. Humble doctor, I will just remind me, I will talk to you in the end, otherwise we'll lose time. Okay. Murphy sign, I will definitely talk to you about it at the end of the class. Okay. I will clear all the doubts. So then it becomes empyema. Now from empyema, what happens? The gallbladder gets stretched so much that the blood vessels which are running in the gallbladder get compressed like this, because it is stretching. You're stretching it, it becomes compressed. There is no blood supply. So when there is no blood supply, the wall of the gallbladder will become necrotic. And what is that called as? That is called as gangrenous gallbladder. Gangrenous gallbladder. So when you have a gangrenous gallbladder, what will happen? That infection will get into the bloodstream, correct? This will go into the bloodstream. So what is this condition called when you have infection inside blood? Infection inside blood. This condition is called as sepsis. Dear students, I want you to try and attempt this as I'm teaching you. Okay, I will probably not wait for the answers, but I want you to try and attempt. So there's nothing wrong in attempting. At least if you attempt something wrong, next time you will know what you have made a mistake and you will make sure you don't make those mistakes. So now in sepsis, if the infection persists, these patients can end up with organ dysfunction, correct? MODS, organ dysfunction, multiple organ dysfunction syndrome, MODS. All these can happen. Okay. So I hope this picture is very clear. This is the pattern of how an acute cholecystitis progress. It will get blocked. It will get filled with mucus. Mucocele will happen. Mucocele, if it gets infected, it will become empyema. Then it will become gangrenous gallbladder. Meanwhile, the infection will travel to blood. The patient can end up with sepsis and MODS. Now let's look at the Tokyo classification. Okay, for grading severity of acute cholecystitis. Tokyo classification for severity of acute cholecystitis. Normally we go 1, 2, 3. In Tokyo, everything is ulta. 3, 2, 1. 3 to 1. Okay, the other way around. MODS, that's what we just ended with, no? So if there is MODS, cardiovascular dysfunction, neurological, respiratory, renal, hepatic or hematological dysfunction, then it is called as Tokyo classification 3. Come back one step before that. What was it? What did we talk about? All the local signs of inflammation: empyema, mucocele, gangrenous gallbladder. See here, local inflammation, gangrenous gallbladder, pericholecystic abscess, emphysematous or an empyema, or in that area if there is a perforation of the gallbladder, then all these fit into grade 2 or moderate acute cholecystitis. And if it is in the just initial stage of cholecystitis, what we spoke about starting, no? Only acute cholecystitis with minimal pericholecystic fluid or mild inflammation, that falls under grade 1. Any doubts or questions so far? Please put it up. Very, very important, because now we are going to start getting in depth into gallbladder diseases now. Now the first line of treatment is to keep them NPO, give them IV fluids, treat them with IV antibiotics. And then based on the grading, we'll see how we are going to treat them. First grade, give antibiotics and do laparoscopic cholecystectomy. Now in grade 2, after you give antibiotics, now we are talking about gangrenous gallbladder, mucocele, empyema, peritonitis, biliary peritonitis, this condition. So after you give antibiotics, either the patient can improve or he can deteriorate, or his condition can worsen. Now if his condition improves, two more things that you need to see: whether the patient is fit for surgery or the patient is not fit for surgery. Now fit for surgery basically means ASA grade 1 or 2, not fit means ASA 3 or 4. Okay, now if he's fit for surgery, go ahead and do a surgery. Now the only criteria is, when you're doing the surgery, make sure you have advanced laparoscopy setup. That means, of course, no such conditions you wouldn't want to operate on your own. You want your HOD or the best surgeon available. So even technical skills come into picture at this point of time. So advanced lab setup should be there when you're operating grade 2 and grade 3. Remember that. Now if he's not fit for surgery because the condition has improved, observe the patient and then do a delayed surgery, delayed lap chole after a few weeks once the patient's condition is better. But if the patient's condition is deteriorating, that means that infection is so bad that the antibiotic is unable to touch that area. So you have to drain that pus which is inside the gallbladder. So if you put a tube inside anything, it is called as ostomy. So if you put a tube inside the gallbladder, it is called as cholecystostomy. Okay, cholecystostomy. So the patient deteriorates, you're going to do cholecystostomy, and once the patient's condition improves, you're going to plan for a delayed laparoscopic cholecystectomy. I hope this part is clear. Now for grade 3, this is when the patient is in MODS. Here also same thing will happen. You're going to give them antibiotics. Two things can happen: either the patient's condition is going to improve or the patient's condition is going to deteriorate, or the third is if the patient has something called as a negative predictors or negative predictor factors. Okay, I will talk to you about it in a second. If the patient condition improves, again same thing: is he fit for surgery or if they are unfit for surgery. Fit for surgery, again laparoscopic cholecystectomy in an advanced setup. If they are unfit for surgery or if the patient's condition is deteriorating, both of these times you will do a cholecystostomy. Now here why we are not going to sit and observe like in grade 2 is, here the patient is in MODS. That means it has gone one stage beyond. So he might transiently improve, but if you leave the pus behind, there is a chance he will relapse. So here don't take a chance. In grade 2 you can observe, in grade 3 you can't observe. You have to do something and drain the pus. So you're going to do a cholecystostomy and then do a delayed surgery, delayed laparoscopic cholecystectomy. Now what are these negative predictors? Three things: serum bilirubin more than 2, if the patient has neurological dysfunction or respiratory dysfunction. Okay, if these are there, then directly cholecystostomy and eventually a delayed laparoscopic cholecystectomy. Don't try to take these patients up for surgery. It can become very detrimental to them. So this is how we are going to manage. Now I've gone into the depths because this is given in Bailey and Lau. Otherwise I would not have touched about all this. It's a bit too much for undergraduate students, but this is given in Bailey and Lau, potential question in AIIMS. Now so far we spoke about diseases where gallstone has actually caused a problem. Can you still operate in conditions where gallstone is not given a problem? That means in asymptomatic gallstones, can you still operate? Yes, and that is called as prophylactic cholecystectomy. There are certain indications for it. Now to remember the indications, I have come up with the mnemonic. Can you see this long gallbladder which is taken out? This was actually done for a Whipple's procedure, but I wanted to remember the image. Look at the size of it. It's that big of a medium-sized artery fossa. It is this big, that gallbladder, this big. Okay. So what will you do when you remove a long gallbladder? You're going to send it to the pathology. Okay, Ranjana ma'am, normally we send it to them. So she will give the reporting, our favorite pathologist. Okay, so long gallbladder for histopathology. So a long common channel, Gallbladder polyp more than 1 centimeter. Please remember, more than 1 centimeter, not less than 1. Gallbladder less than 1 centimeter, you are only going to observe. If it is more than 1 centimeter, risk of cancer, so you have to operate. If the patient is undergoing bariatric surgery, if the patient has hemolytic anemia or porcelain gallbladder, these are all indications for doing a prophylactic cholecystectomy. Amongst this, gallbladder polyp more than 1 centimeter, porcelain gallbladder, and gallstones more than 2.5 to 3 centimeters are all risk factors. These are all risk factors for developing CA gallbladder. Okay, risk factors for developing CA gallbladder. Now, during laparoscopic cholecystectomy, there is an important concept called as critical view of safety, where you see only two structures entering the gallbladder, that is the cystic duct and the cystic artery. Now, they can ask you to look at this critical view of safety. How much dissection should you do? It is 2 centimeters of the cystic plate. 2 centimeters of the cystic plate. And in very difficult scenarios, you can give the patient ICG which will delineate the CBD so that you don't damage the CBD. So the idea of this critical view of safety is to safeguard the CBD, safeguard or prevent CBD injuries. Now the other safety measures that they have taken, two things are there. One is the R4U line, which means the Ruvier sulcus, segment 4 of liver, and the umbilical fissure. This umbilical fissure is nothing but your falciform ligament. You know, the falciform ligament will go and split the liver into right and left lobe, no? In the not the actual Coynard's classification. It actually splits the liver non-anatomically into right and left lobe. So that is where the CBD is. So the idea is if you are above that line, you will not reach the CBD because CBD is on this side. So don't cross that line. Don't cross the umbilical fissure. So the risk of damage, see, this is where the CBD is. This is the umbilical fissure, Ruvier sulcus, segment 4. So if you are above this line, you will not damage the CBD. That is the idea. One more concept is the be safe concept. All that saying is if you identify these 5 structures, the risk of complication is less. If you identify CBD, obviously you are not going to damage it. If you identify Ruvier sulcus, you have to stay above it. If you identify the right hepatic artery, that Moynihan's curve and all, whatever we spoke about, the risk of injury is less because you've identified it and you'll stay away from it. If you identify the umbilical fissure, again, you're not going to go below it because we know that is where the CBD is. Then they say identify the duodenum, because sometimes you can have this cholecystoenteric fistula you can have. So make sure you identify the duodenum, separate it, push it down and safeguard the duodenum to prevent any other complication. So if you identify these 5 structures, that is the B, S, A, F and E, the risk of complication is very, very low. 2 more important points. One is timeout, one is bailout. Timeout, very simple example I can give you in IPL, whatever the match is going on. If someone can give me an update again, please. Okay. Timeout is, let us say in the first 6 overs, opponent team has scored 100 runs. You are under pressure. So what you do immediately after 6 overs, you'll take a timeout, come re-strategize, go back inside and play. Same thing here also. When there is a lot of bleeding or very difficult dissection and you don't know where you're going, take a breather, come back, relax, go with an open mind, look at it again. That is called as timeout. The other one is bailout procedure. That means idea is don't cause CBD damage. Even if you don't complete the procedure, don't cause any harm and come out. These are called as bailout procedures, and I've created a mnemonic for it with the initial letters of bailout itself. Forget about B and T. Let's look at the rest. A is abort the procedure and come out. I is insert a tube, that is cholecystostomy. L is leave behind a little bit of gallbladder, that is called subtotal cholecystectomy. O is convert to an open surgery. U is take a U-turn. Normally we go from cystic duct towards fundus. So if cystic duct are unable to identify and you're unable to define the critical view of safety, come from fundus to back. So you have taken a U-turn and you're coming back. That is called as a fundus first technique. Now let's move on to biliary duct or bile duct injuries. We know we have Strasbourg classification. You have A to D, and in E you have E1 to E5. Okay, all these are based on location of injury. Now this E1 to E5, is also called as the bismuth classification. Here you again have, here it is type 1, sorry, it is type 1, not E1 to E5, this is type 1. Okay, this is bismuth classification. Now in last year's INICET, they had asked this question: what is the classification of CBD injury which takes into account vascular as well as ductal injuries? Okay, so remember, Strasbourg and bismuth both are based on the location. McMahon, okay, this is based on the diameter or width of bile duct which is injured. Okay, width that is injured. And Hanover and Stewart Way take into consideration vascular injuries as well. Vascular injuries. Okay, bismuth is type, yes, bismuth is type, okay, type 1 to type 4. Now, how are you going to manage these bile duct injuries? Either it will be intra-op or post-op. Intra-op means immediately when I'm operating only, I realize I've made a mistake and I'm going to try and rectify it. So all that depends on the diameter of the duct that is injured. If it is less than 50% of the duct, all I have to do is primarily repair it. Stitch it up then and there with the help of a T-tube. Okay, so primary repair over a T-tube. If it is more than 50%, usually this area is very unhealthy. So what they suggest is, they are saying resect this entire segment, resect the segment and do a end-to-end anastomosis. So resect and do end-to-end anastomosis with a T-tube. And if there is a more than 1 centimeter segment loss, for some reason more than 1 centimeter segment loss of CBD is there, that is when you're going to do a bilioenteric anastomosis. That is a Roux-en-Y hepatico-jejunostomy. That is when you're going to do a Roux-en-Y hepatico or a choledoco-jejunostomy. So this is intra-op if you have identified. If it is post-op, you're going to follow it in the same heading. First thing you're going to do is control the infection, because these patients will have biliary leak or biliary collection. So first thing is control the infection, give them antibiotics, but that bilioma which is there has to be drained. So you will do USG plus aspiration. Next you have to delineate the anatomy. This is done with the help of MRCP. And then you will re-establish continuity again with the bilioenteric anastomosis once the patient is stable. So this is how you're going to manage bile duct injuries. Now in pregnancy, in first and third trimester, you are going to conservatively manage the patient. In second trimester, you are going to operate on the patient. Surgery is the treatment of choice in second trimester. First and third trimester, it is conservative management. In third trimester, conservatively manage till the time of delivery or your cesarean section, and surgery is done 6 weeks later. 6 weeks later. Okay, surgery is done 6 weeks later. Last few slides on gallbladder. T1A gallbladder cancer, that means only up to the lamina propria a cholecystectomy is enough. T1B and beyond T1B, that means T2, T3, T4, you're going to do a extended or a radical cholecystectomy, which involves removal of gallbladder, 2 centimeters of the surrounding liver bed, and lymph nodes, very very important, hepatogastric, hepatoduodenal, the porta group of lymph nodes, all these have to be removed, and plus or minus bile duct depending upon where the cancer is. Okay, so this is what an extended or radical cholecystectomy is. And when it comes to chemotherapy, the drug of choice is gemcitabine. Okay, and the indication is T4 disease, presence of nodes, or a R1 resection. So let's solve a few questions. I hope you are there. Thank you, Himanshu. Yeah, 54 for 2. So back to square one. We know what to look forward to. Okay, a lady presents to the hospital with abdominal pain. Ultrasound shows multiple stones in the gallbladder. CBD is dilated. Okay, I want you guys to answer this. CBD is dilated. bilirubin is 0.8, alkaline phosphatase is elevated, GGT is elevated, gamma glutamyl transferase is elevated. So in short, CBD dilated, LFT is deranged. What is the next best step? Do you want to do MRCP or ERCP? MRCP or ERCP? What do you want to do? Can somebody put up the answer? MRCP or ERCP? The answer is MRCP. Okay. Only after you have confirmed that there are stones in the CBD, because even now it can be a stricture in the CBD. Are you getting the point? Even now it can be a stricture in the CBD. So doing an ERCP doesn't make sense. It can be a tumor in the CBD. We don't know. The gallstones might be asymptomatic, correct? So for confirmation whether there is stones, you have to do an MRCP. After you have confirmed that there are stones, then only you are going to plan a ERCP. This question, this we already discussed. Which of the classification? Devavarshini, I just gave you the answer. It is supposed to be MRCP. After confirmation of the stone, then you're going to do ERCP. So which classification of bile duct injury takes into account both vascular as well as location of the injury? Can anyone tell me this? Vascular as well as location, we've covered this. Hanover classification. Okay, we just covered that. Strasbourg and Bismuth, I told you location. McMahon is width. Hanover and Stewart Way, both are vascular injuries. Okay, both are vascular injuries. Now, elderly lady was diagnosed with gallbladder polyp. Which of the following is not a risk factor? We have covered this as well. Okay, which of the following is not a risk factor? Porcelain gallbladder is a risk factor. Yes. Primary sclerosing cholangitis is a risk factor. Yes. Gallstones more than 2.5 to 3 centimeters is a risk factor. Yes. What about gallbladder polyp? Gallbladder polyp more than 1 centimeter is a risk factor. Less than 1 centimeter is not a risk factor. So the correct answer here is gallbladder polyp less than 1 centimeter in size. Excellent answer, Shabir. Excellent answer, Devavarshini. Good. Sneha. Are you guys tired? Because I still have 2 or 3 topics left. If you're tired, we'll wind up, or we will cover shock, trauma, and we can skip a few topics. If you guys want me to wind up, I'll wind up, because it's been 2 hours. Sometimes the attention span tends to wake out, and we'll try to see if we can reschedule another class. If you can put a message saying please continue or wind up, we will wind up and just try to finish the important bits. Can I get some response? So while you're answering, I will start off, but if I see any message saying if you're requesting me to wind up, I will try and wind up. We can cover some more topics. Okay, Shabir, done. So we'll do that. Can you tell us important topics, Neha? Whatever I'm covering, everything is important, Neha. Whatever I'm covering, everything are high yield topics. Everything have had PYQs, very, very important from INICET point of view. I will do that, Neha. We'll again cover up what are the important topics there. Okay. So quickly, let's try and finish it a bit more faster now. We'll pick up the pace. There is shock. In shock, hypovolemic shock is very important, and you need to know the classification of hypovolemic shock. Now, how do you remember this? If people are familiar with tennis and the tennis's scoring system, if you watch tennis or if you have played tennis, you'll know the scoring system is 15, 30, 40, and then game. Okay, game. So how we are going to remember? Class 1 is 15% blood loss, class 2 is 15 to 30, class 3 is 30 to 40%, and class 4 is more than 40%. That is how we are going to remember how to assess the amount of blood loss in hypovolemic shock. Now, if you want to remember this in terms of blood volume, imagine the first one is blood donation. So you're going to donate 500 ml of blood, correct? When you donate, you're going to donate 500 ml, nothing's going to happen. From now on, you go on adding 500 ml everywhere. 1000 ml, 1500 ml, 2000 ml. So please remember, in type 1, more or less nothing will change. Most of it will remain the same except for a little bit of lactic acidosis and base deficit. Everything else will remain more or less normal. In type 2, there is significant amount of blood loss, but the BP does not drop. BP will remain normal. BP will remain normal. How does it remain normal? To compensate, the heart rate will increase. To compensate for the low BP, the heart rate will increase. That is why this is called as compensated shock. So class 2 is called as compensated shock because the heart rate is compensating for BP. Now in class 3, this is for the first time that the patient will have hypotension. For the first time the patient will have hypotension. In spite of all the compensation, there is continued blood loss, or the blood loss is so significant that it can't compensate. Then these two are called as decompensated shock, decompensated hemorrhagic shock. I hope this part is clear for you. So hypotension is seen for the first time in class 3. Class 3 is very, very important. A lot of things will happen here. Urine output will reduce for the first time. Patient will become oligouric. First time the urine output will reduce. Consciousness, the patient will become drowsy. Lactic acidosis will increase. Base deficit will increase. All these happen for the first time in class 3. So class 3 is very, very important. Class 4 means you have lost the game. Okay. That means BP is not recordable. Heart rate is also not recordable or very feeble. Okay. Urine output would have become 0. That means anuric. There is no urine output at all. Kidneys have failed. Consciousness, the patient has become unconscious. So whatever bad things you can think of, go on writing it, and this is class 4. This is decompensated shock. Now this class 2, class 3, class 4, they are also called as mild, moderate, severe. Okay, mild, moderate, severe. Very, very important is class 3 shock. Now I will quickly run through this. There is a definition called as SIRS. Temperature, there is a criteria. Tachycardia, there is a criteria. Tachypnea and total leukocyte, there is a criteria. So if any two of these are present, then you're going to call it as SIRS. SIRS basically means systemic inflammatory response syndrome. That means there is a inflammatory response seen in the patient. Okay, there is an inflammatory response seen in the patient because of some condition. Now the condition can even be a surgery, it can be an infection. If it happens because of infection, that is SIRS plus infection, you're going to call it as sepsis. Okay. Now this sepsis, if it is associated with organ dysfunction, you're going to call it as severe sepsis. And if it is associated with shock, that is low BP, you're going to call it as septic shock. Now all this I've told you so far, this is what is given in Bailey and Love. But the problem is Bailey and Love, this particular chapter is outdated. The recent guidelines is the Sepsis 4. Sepsis 4.0. So in Sepsis 4.0, SIRS is no longer a part. Severe sepsis is no longer a part. Only sepsis and septic shock is there. And the two criteria for definition of sepsis is 1, lactic acid level is more than 2. Second is, in spite of vasopressors, the MAP continued to be less than 65 millimeters of mercury. Okay, this is the criteria for calling it sepsis. This is the definition. Okay, sepsis and septic shock. Then there is something called as Q-SOFA score. There are 3 components of Q-SOFA score. First one is BP. Second one is the neurological status. That means GCS is less than 15. Third one is respiratory rate more than 22. Okay. So these are components of Q-SOFA. Now correct, in BP it is less than 100 millimeters of mercury. So remember this. Now I will give you an easy way of remembering Q-SOFA score, because the question that has been asked is all of the following except are components of Q-SOFA score. Easiest way to remember is how Christians do, like this. Okay, brain GCS less than 15. Don't consider this as heart rate, because heart rate is important for BP. Correct, heart is important for BP. So BP less than 100. On either side lungs are there. Respiratory rate more than 22. So remember this, you will remember components of Q-SOFA score. I hope that was easy and you can easily remember that bit. Next, there is something called as surviving sepsis campaign. So here there are a set of tasks that you need to do, and these tasks are called as bundles or resuscitation bundles or SSC bundles. Now, if I am postgraduate, I tell my intern, I give them a list of work. For this patient, do dressing. For this patient, you go collect blood. For this patient, you give the requisition. For this patient, you write consent. And I tell him all this has to be finished within a certain period of time. So this is a task which I've given in a certain period of time. This is called as a bundle. So for sepsis also, there is something called bundle, and this bundle has to be achieved within a certain duration. So the task that you're going to do is, first you're going to measure lactic acid levels. Next you're going to next you're going to take a blood culture. Next you're going to give the patient antibiotics. After you take the culture, then you're going to give the patient IV fluid to maintain the mean arterial pressure more than 65. This is the first set of tasks that you're going to do. Now, in spite of doing all this, let us say the BP does not pick up. Then you're going to give vasopressors. Again, here, if you're trying to maintain the MAP more than 65, the most common or the first vasopressor you're going to give is noradrenaline. And in spite of that, if the patient tends to worsen, that means you have to check whether it can be something as simple as the BP cuff not reading it properly also. But you need to know whether the sepsis is worsening or not. So to check that, you're going to remeasure lactate. Now earlier, all this was supposed to be done within 6 hours. So they used to call it as a 6-hour bundle. Then they made it 3-hour bundle. Now they are saying we do it as early as possible. Now it is even called as the 1-hour bundle. So that means if you do all this within 1 hour of the patient presenting to you, the outcome is that much better. Okay, so this was about surviving sepsis campaign and its bundles. Now something similar is the sepsis 6. Okay, this is from a different guideline. This is from the UK Sepsis Trust. That is where they have come up with the sepsis 6. Here they are saying give 3: IV fluid, IV antibiotics, and oxygen. Now we are going to take 3. That means take blood for 3 different tests. First, we already know it is important to measure lactic acid levels. Second, you are going to check for the total leukocyte count. And third, you are going to send the blood for culture. So this is give 3, take 3. All these are very important points. This is of extreme importance. You need to know how to differentiate between the various types of shock. I want you to be concentrating along with me for the next 2 minutes. That's all. We'll finish this very fast. In hypovolemic shock, what happens? There is blood loss. So what the body does, it tries to save as much blood as possible and redirect it towards the important organs like heart, the lung, the brain. So what will happen? The peripheries, there is no blood, because peripheries is not considered important. So if peripheries has no blood, periphery will become cold. Now why will it become cold? There is vasoconstriction. So patients with hypovolemic shock will have cold peripheries and raised peripheral vascular resistance because of vasoconstriction. And capillary refill time will be prolonged. That means after I press and release, the blood supply should come back, but because there is no blood coming, it takes a very long time for the capillary to refill. So capillary refill time is prolonged. Now next one is cardiogenic or obstructive shock. The cardiogenic or the obstructive shock. Now take a simple scenario where there is a construction of a flyover going on or a metro construction going on. I'm sure all of you would have experienced this. That area is normally a bottleneck or a traffic jam. Something has got blocked there. So all the cars will pile up. There is a huge traffic jam behind. So in cardiogenic shock, the heart is not pumping. In obstructive shock, the heart is not allowed to pump because there is something which is obstructing or preventing the heart from pumping. So in both the scenarios, because the heart is not pumping, there is a traffic jam of all the venous blood. So traffic jam of all the venous blood, where are you going to see? Dilated veins, correct? Dilated veins. So which is that reading you're going to see? JVP. Okay. Raised JVP is only seen in cardiogenic or obstructive shock. Please remember, raised JVP is cardiogenic or obstructive shock. Next one is septic shock or anaphylactic shock. So here what happens in septic and anaphylactic shock is the vessels get dilated. Okay, the vessels get dilated. So no matter how much fluid you are giving, everything is oozing out in between the blood vessels. So the patient's edema is worsening, but the BP is not improving. Now there is vasodilatation. That means peripheral vascular resistance is very low. Peripheries are warm because of the the peripheries are warm because of vasodilatation, and capillary refill time is very fast. As soon as you press and release, because it's vasodilatation, it will easily fill up very fast. Okay, so this is the feature you're going to see in septic and anaphylactic. So how do you differentiate between septic versus anaphylactic? All the features will remain the same. History. In anaphylactic, they'll give you history of blood transfusion, okay, blood transfusion, or some sort of an insect bite. They'll give you this history. That means it is an anaphylactic shock. Otherwise, the answer is a septic shock. Last one is a neurogenic shock. In neurogenic shock, there is complete transection of the spinal cord. So there is loss of sympathetic reflex. So when there is loss of sympathetic reflex, the patient will have bradycardia. Heart rate is low, and the patient will have vasodilatation. That means there is reduced peripheral vascular resistance. So it is a sort of warm shock, but bradycardia. So remember, the only shock with bradycardia is a neurogenic shock. Now they'll give you scenarios like patient has undergone an RTA, patient has an open wound, patient also sustained injury to the cervical cord, patient has bradycardia. What do you think is the type of shock? Common sense, you will think it is hypovolemic shock because he has RTA. But bradycardia is seen in neurogenic shock. That little bit of common sense you should use at that point of time. So now we've covered shock. Let's solve a few questions. Which of the following are seen in neurogenic shock? Is it hypertension and bradycardia? No, because you're going to have hypotension there. So which is the only other option with bradycardia? Hypotension. So the answer is hypotension and bradycardia are seen in neurogenic shock. Which of the following are components of Q-SOFA scoring? Respiratory rate is a component. Yes. Blood pressure is a component. Yes. CNS feature is a component. I told you, no, CNS, blood pressure, respiratory rate. This is how we're going to remember Q-SOFA scoring. So A, B, C, the answer is option B. Correct? Yes. Yes, Devavarshini. Yes, Shabir. Excellent. Excellent. Okay. Now let's move on to esophageal disorders. I'll be a bit quick here. In esophageal disorders, only two things we're going to discuss. One is hiatus hernia, one is motility disorders. Okay, hiatus hernia, motility disorders is the only thing that we're going to cover. Hiatus hernia basically means the gastroesophageal junction, what is supposed to be at the level of the diaphragmatic crura, can migrate upwards, and there is a loss of function and acid from the stomach gets reflux. So the patient will have gastroesophageal reflux because of a hiatus hernia. Now you have four types: type 1, type 2, type 3 and type 4. Type 1 is called a sliding hiatus hernia, where the OG junction, you can see this white dot, right? White dot. So the white dot gets pulled up above the level of the crura. Now in type 1, you can either manage it conservatively or you can operate on the patient. Both options are available. Whereas in type 2, the OG junction is the same place, but there is a knuckle of the stomach or the greater curvature of the fundus which goes inside the chest. Now this one is dangerous. The reason being, this part of the stomach can twist and undergo volvulus. Okay, it can twist and undergo volvulus and can cause necrosis. So this is a surgical emergency. So surgery and only surgery is the treatment whenever you have a rolling component. Now type 3, along with sliding component, you have a rolling component. So what is the line of management here? Is it conservative or surgery? It is always surgery as long as you have a rolling component. If the rolling component is there, it is always surgery. And the last one is type 4, where instead of stomach, you can either have small intestine, large intestine, Sometimes even the liver or spleen also can get herniated through that gap. So this is hiatus hernia type 1 to type 4. Now just for knowledge or just for curiosity, I will show you. Let us assume this is the stomach. This is the stomach. So the first image is an endoscopic image. I will explain to you what I have done here. I have put in the endoscope inside and I have turned the endoscope completely like the shape of a J, and I am looking at the OG junction. So normally the OG junction, if it is patent, it will snugly fit inside the OG junction. But in this particular patient, you can see this is the scope, this black color line what you're seeing. I will zoom it in for you. Can you see this black color line that you're seeing here? That is my endoscope. I'm looking back towards the endoscope here. So you can see there is a big gap next to this area. So this is a hiatus hernia. Okay. Now the same thing if I'm doing it laparoscopically. Okay. Before that I will show you. This is where the crura is. Correct. This is where the crura is. So if I am doing a laparoscopy surgery, that means I'm seeing from the outside. Again, in between the crura, only the esophagus should come. I should not be able to see anything else inside this triangle. So this is a laparoscopic image. This is right crura, left crura, and you can see esophagus is only in this part. You can see such a big gap here. So this is also a hiatus hernia. So this is a laparoscopy view and this is a endoscopy view. This was just for knowledge. Okay, so I just want you to keep an eye on it. Now we'll move on to motility disorders. One question has been asked and there is a potential that they can ask another one on this. Okay, that's the reason I'm covering this. Two important concepts that you need to know. There is something called IRP, which is integrated relaxation pressure. Relaxation happens where lower end of esophagus. So this IRP is nothing but lower end pressure. Lower end pressure. So normal value should be less than 15 millimeters of mercury. If it is more than 15 millimeters of mercury, that means there is tight constriction there. The patient is unable to swallow food and the patient has achalasia cardia. So achalasia cardia is where the IRP is more than 50. Next one is your DCI, that is distal contractile integral. So remember, integral means integration, differentiation. So you're adding up. So this is addition of pressures along the esophagus. So this is the esophagus. You're going to add up all the pressures at different levels and you're going to take an average, and that will tell you what the average pressure of peristalsis is inside the esophagus. So normal value is between 450 to 8000 millimeters of mercury. So less than 450 means this is weak peristalsis. Less than 450. More than 8000 means, if it is more than 8000, this is a jackhammer esophagus. Now have a look at this. We already spoke about IRP. If IRP is more than 15 millimeters, it is achalasia. This we already discussed. This is achalasia. So in achalasia there are three types: type 1, type 2, type 3. Type 1 is failed contraction. Type 2 you're going to have panesophageal pressurization, and in type 3 you're going to have premature or spastic contractions. This unfortunately you have to mug up, and I really don't know how else I can tell you. You just have to mug up these 3 points. Now this is a case of achalasia cardia which we recently treated. I had done an endoscopy for this patient. You can see nice huge dilated esophagus with a narrowing, and you can see there is some amount of food residue here. Okay, so when I do an endoscopy, I will see food residue. There will be a dilated and a tortuous esophagus like this. When you do a barium study, you will either find a bird beak or a rat's tail appearance. And when you do a high resolution manometry, here the sensors are placed 1 centimeter apart, and you're going to use 36 different sensors. Okay, so these are the investigations needed for achalasia cardia. Treatment, you can either have medical line or you can even inject botulinum. Botulinum has a high chance of recurrence and there is a risk of scarring being formed in that area. Okay, so normally these are not used. Instead, what we normally use is a balloon dilatation. Okay, a balloon dilatation, this is the preferred treatment. Now you might need more than one sitting. That means you might have to use this balloon dilatation more than once. Apart from that, you have a surgical procedure called as the Heller's myotomy. Now they can ask you how much muscle you're going to divide. You're going to divide approximately 6 centimeters. That means on the esophagus 6 centimeters, on the stomach 2 to 3 centimeters, distally stomach 2 to 3 centimeters. And after you have done this, because the sphincter is wide open, these patients can have reflux. So you have to add in a fundoplication to this. You have to add in a fundoplication, and the type of fundoplication you're going to do here is partial, not complete wrap. You're going to do a partial wrap. Okay, either an anterior or a posterior, but it has to be a partial wrap. And the outcomes of surgery are better in type 1 and type 2 achalasia. And very rarely you might have to end up doing an esophagectomy for these patients as well. Now, apart from surgery, you also have this procedure called as POEM. Whatever in surgery we did laparoscopically, we came outside and cut the muscle. The same muscle they are cutting while doing an endoscopy, that is called as POEM, which stands for per oral endoscopic myotomy. Per oral endoscopic myotomy, you can see here, this is an image based question. They can put this up and ask you to identify the procedure. So please be careful. Look at this. They've got the endoscope here. They've cut the mucosa. They've gone in here. Now they're cutting the muscle. Then they're coming back out of the mucosa and stitching it up. Okay. So this is a per oral endoscopic myotomy. Very short bit about foreign bodies. The most common site where foreign bodies can be found are the cricopharynx, because this is the narrowest area. So if any foreign body slips beyond the cricopharynx, nothing to be done. It will come out of the rectum, nothing to be done, because it's the most narrowest area in the entire GI tract. So if it is crossed beyond this, nothing to be done. Certain exceptions are there where even if it's crossed the cricopharynx, where you should attempt and remove it. One is if it's a sharp object. If it's a sharp object, you're going to remove it, or if it's a button battery. So here you can see in this X-ray, this was of a child which had done endoscopy recently. The child had swallowed a battery and come. So if you see, you can see that it's in the area of a radiopaque object in the area of the stomach. So I did an endoscopy for this patient. If I zoom in, I hope you can see there is a nice battery sitting here like this. Okay, the small batteries what they use to remove that which they use for all these watches and small toys. So there was a battery sitting there, so I used the snare and I got that battery out. Now for confirmation that it was me, you can see this is actually me. Okay, doing the endoscopy while I was getting the battery out. So now let's quickly cover a few questions. Which of the following investigations is not needed for the diagnosis of this condition? So this condition, what you can see here is achalasia. Okay. So will you do a barium study? Yes. Will you do an endoscopy? Yes. Will you do manometry? Yes. This is the gold standard. Will you do a 24-hour pH monitoring? No. 24-hour pH monitoring is done for what condition? It is done for GERD. So where you're going to look for the D-Meesters scoring. This is done for GERD and not for, correct Shabir, correct. So 24-hour pH monitoring is not done for achalasia. Next, a patient presents with dysphagia. Manometry showed abnormal spastic contractions. Remember this, spastic contractions in the esophagus. More than 450 millimeters of mercury with a high lower esophageal pressure. We told you high lower esophageal pressure means more than 15 millimeters of mercury, IRP more than 15. So next time they will not say high LES, they will say IRP is raised. Sorry. They will say IRP is elevated more than 15 millimeters of mercury. Okay, be careful. So this is achalasia. Achalasia with spastic is seen in type 3. So type 1 is failed peristalsis. Type 2 is pan-esophageal pressurization. Type 3 is spastic. And jackhammer esophagus, what did I tell you? DCI is more than 8,000 millimeters of mercury. So this was about esophagus and its disorders. Now quickly, very small bits in trauma. Okay, we are coming to the end. I'm probably just last few slides, we'll just wind up very fast. One question or one common answer: why do we always go A, B, C, D, E in this particular order? Why can't we come like Tokyo classification? No, why can't you come ulta severity, type 3, type 2, type 1? So why can't you come E, D, C, B and A? This is because of something called as a timeline concept. Timeline concept. So the idea behind timeline concept is from the time of injury. So this line is injury. So from the time of injury to time of death, okay, to time of death, they found that the shortest duration was found in airway obstruction. Shortest duration. That is why they're saying don't waste time doing GCS and all. Because if the airway is obstructed, the patient will die immediately. So first thing you're supposed to do is secure the airway, because the patient can die very fast. So that time there's no point saying, oh, I did a good GCS, I did a good disability full evaluation. Rubbish, doesn't make sense. So I hope you understand why this A, B, C, D, E is in this order. It is timeline concept. Now the next question in A stands for airway and cervical spine fixation. Okay, airway and C-spine fixation. Airway and cervical spine fixation. Here C-spine should be done first. C-spine first and then airway. The reason being, whenever we are intubating a patient, we tend to extend the neck. So if there is a cervical injury and you try to extend the neck, you will worsen that cervical injury. It becomes very, very dangerous for the patient. You will worsen the cervical injury. So first thing is secure. That means whatever is a partial tear can become a complete tear, okay, in the cervical spinal cord. So first is secure the cervical spine and then try and access the airway. Now airway, the most definitive way is to do a endotracheal intubation. Emergency procedure is a cricothyroidotomy, and in emergency the definite modality is a tracheostomy. So normally this is done when you have severe maxillofacial injuries, when you can't access the oral or the nasal route. That is when you're going to do a cricothyroidotomy or a tracheostomy. So this is a Philadelphia's hard collar. They will ask you this. This is for cervical spine fixation. Philadelphia hard collar. Now if you are at the site of the accident and you don't have access to this collar, you're going to do this. You're going to put your hand next to the spine and you're going to head and you're going to hold it tight and straight. So this is called as inline C-spine fixation or immobilization. Okay, inline of the cord, you're trying to hold the neck straight. Now coming to breathing, the main thing you're concerned about in breathing is a tension pneumothorax. And what is the first thing that you're going to do when you get a tension pneumothorax? Put in a wide bore needle. So in adults, you're going to put it in the 5th intercostal space, mid axillary line. For those of you who are confused, is it anterior axillary line or mid axillary line? Both are accepted, because Schwartz textbook says anterior axillary line, but the ATLS manual, the 10th edition, says mid axillary line, and the 10th edition of the ATLS is a bit more recent, so we can go with either of the two, because see, the gap between mid axillary and anterior axillary is hardly about 4 or 5 centimeters. And when you're putting a needle, you're not going to sit and measure that. You're trying to save the patient's life. So I don't think they will ask you a question between mid and anterior axillary line. Amongst the two, I would personally prefer mid axillary line. I had accepted anterior axillary for some time, but then once I went through the ATLS manual, the 10th edition, I have changed my opinion, and I think it should be mid axillary line because it's easy for you guys to remember. For children, you're going to put it in the 2nd intercostal space in the mid clavicular line. Now sometimes if the patient is very obese, your needle will not go through till the level of the pleural cavity. That is when you will make a cut spread open all the muscles, put your finger inside the thoracic cavity and open up and allow the air to come out, and that is called as a finger thoracostomy. So if needle thoracocentesis fails, if this fails, then you're going to do a finger thoracostomy, normally done for obese patients. Next, moving to circulation, the amount of fluid you're going to give is 1 liter stat followed by 250 ml bolus. Earlier this was 2 liters. Now this has become 1 liter. Now I'll tell you why. Now there is a concept called as damage control resuscitation. So let's understand that with the help of an example. Let us assume this is a beer keg. Okay, this entire thing is a beer keg. Okay, entire thing is filled with beer. There are multiple holes now and all the beer is leaking out. Now right now you don't have beer available at hand to fill this keg continuously. So what you will do, whatever is available at hand right now is water. So you're going to start filling it up with water and you're trying to compensate for whatever beer is being lost. This is the first thing. So if you try to convert this analogy to human body, patient is bleeding from somewhere. You don't have blood available right now. So you're going to give the patient IV fluid rather than blood. This is the analogy. Now let's come back to this. So right now when you have ongoing loss of beer, will you continue to just pump fluids or your intention is to stop these holes? How you're going to stop is different. Put a finger, put a plaster, something, some basic thing you have to do to stop the hole. That is the intention, correct? So there's no point just continuously adding water. Idea is to stop or plug the holes. So that is the concept of damage control resuscitation. Only thing is stop bleeding or stop the contamination. That means if there is a viscous, hollow viscous which is injured or something, your job is to go and close it and get out. Stop bleeding or stop the contamination. So this I hope you understood. So the idea is to first stop the bleeding, then later on see how well you're going to stop. If you want, change the shape of the beer keg, put an additional layer inside, change the color, change the location, whatever, that and all you do later. So anatomical restoration and all or a definite surgery has to be done later. Primary intention is to stop the bleeding. Now let us come to this point. Whenever I am adding water into this beer keg, I am diluting the beer. Okay, if you dilute the beer, is it tastier or not? It is less, correct? It becomes less and less tasty because you are diluting it with water. People with experience should tell. Okay, so the more and more dilute it gets, you are worsening the taste of the beer. Now consider the same thing. The more and more fluid you give, the blood is becoming diluted. Okay, blood is becoming diluted. Not only blood, even platelets and clotting factors are becoming diluted. So this condition is called as dilutional coagulopathy. Okay, this is called as dilutional coagulopathy. Now what is happening? For bleeding to stop, you also need good amount of clotting factors. Now if these clotting factors get diluted, that means the quantity of active particles will come down. So this clotting will not happen and the patient will continue to bleed. So the reason why I am telling you all this is, that is why they say only 1 liter of fluid. Don't get overexcited and put 2 liters of fluid and say, oh, I am going to aggressively resuscitate this patient. So when you do this, you're actually worsening or causing dilutional coagulopathy and worsening the patient's condition. This is what I'm trying to point out to you guys with all this example, whether for the exam or in life when you're handling a patient. Know that you shouldn't over resuscitate the patient. Now, best thing to replace lost beer is fresh beer. So best thing to replace blood is blood again. Okay, so ideal you need to have blood transfusion, which you will not get immediately. So you're going to use fluids. Fluids also you're going to use crystalloids. Crystalloids also 1 liter and then 250 ml bolus. If the BP continues to drop, take the patient to OT and first stop the bleeding. Do a damage control resuscitation. Now there are certain indications for this damage control resuscitation. Of this I want you to remember the physiological parameters. If the patient has hypothermia, pH is 7.2, lactate more than 5, PT being deranged more than 16, APTT more than 60 seconds, More than 10 units of blood are transfused and is still losing blood means major bleeding is happening, operate immediately. Or if the systolic BP is less than 90 millimeters for more than 1 hour, all these are indications for a damage control surgery or damage control resuscitation. This can be a potential question. What are the stages of damage control surgery? First, like I told you, you have to identify which patient needs damage control surgery. Second thing, you're going to stop the bleeding, take him to OT, stop the bleeding. Third, you're going to resuscitate the patient in ICU. Like for example, there is a, let's say, an aortic tear and a duodenal tear. I will go inside, I will stitch up the aorta. I will not do the anastomosis of duodenum because it looks very unhealthy. So I'll just close the two ends, get out. Now either way I have to go back in some time and re-anastomose the duodenum. So I'll not close the abdomen. I'll only do a laparoscopy. Then I'll take him back to the ICU. I will let him recover from all that blood loss, let him get better. Then 2 or 3 days later, I will take him up for a definitive surgery where I get him back to the OT. Now I will stitch up the duodenum and then finally I'm going to close the abdomen. So this is a potential question where they will ask you what are the stages of damage control surgery. So quick question, which of the following is the correct sequence of managing patients with an RTA? A, B, C, D, E and then followed by secondary survey. In A, I told you it is C-spine first, then followed by airway. Okay, so remember this. So cervical spine first, followed by airway securing with the help of intubation. IV cannula insertion comes under C, that is circulation. CECT comes under second survey or whole body CT scan. So this is the same order in which you're going to do. So the answer will be 1, 2, 3 and 4. Two more slides, one on hernia. What are the ideal mesh characteristics? It should be synthetic so that it doesn't cause too much of a reaction. It should be a net mesh like this with pores so that it allows the ingrowth of tissues. Correct, Aishwarya? So that it allows the ingrowth of tissues so that the mesh will become very strong or that muscle or that area will become very strong. It should be lightweight mesh so that it doesn't cause any stiffness in that area. Pore size should be at least 1 millimeter. That means macroporous. Macroporous. So they will ask you, ideal mesh will be lightweight and macroporous. These are the combinations which they can ask. And there is a concept called as mesh shrinkage or mesh contracture. This can happen up to 50%. 50% of the mesh can shrink. And that is the reason they say a minimum overlap of 5 centimeters is needed. Minimum. Himanshu, C, A, B, C, D. That is what we have answered here, Himanshu. It's 1, 2, 3, 4 in that particular order. If you have any doubts, I'll take it again in the end. We are almost come to the end. Just one more slide after this. So 5 centimeter overlap. That is necessary to compensate for this 50% mesh contracture. Now there is a European Hernia Society guidelines and a classification for identifying inguinal hernia. There is lateral, medial, femoral. Lateral and medial are with inferior epigastric artery in mind. P is primary, R is recurrent, and 1, 2, 3 is the finger breadths, or how many fingers the defect will allow. Okay, how many fingers the defect will allow. So that is finger breadth. So each finger breadth is 1.5 centimeter. So they can give you a classification and say, what is this hernia? So if somebody says right sided primary L1, if they give you like this, it basically means right sided primary. What hernia is lateral to the inferior epigastric artery? The hernia which is lateral to the inferior epigastric artery is an indirect inguinal hernia. So it's an indirect inguinal hernia which is of size 1 finger breadth, because they have written 1 there, or in centimeters it is 1.5 centimeters. I hope you understood this. This is a potential question. That's why I've just put up just enough for you guys to understand this, more for you guys to sit and revise. In case this question comes up, just take 2 seconds and try to answer it. Correct, Devavarshini. Excellent answer. Okay, it is an indirect inguinal hernia. So this is technically my last slide. So far whatever I've covered for you is a glimpse into what all we have done in our app, that is a Manipal Medes app. And I repeat, please subscribe to the YouTube channel and click on the bell icon, very very important, otherwise you will not get the updates or the latest videos that have been released there. Okay, we have some amazing group of teachers here who have put in their heart and soul, and I have personally gone through the content, and we have actually spoken amongst ourselves to make sure that we give you maximum content in a very short and a concise manner, like how I've attempted to do today. How successful I am, I hope to hear from you guys. So please click on the bell icon. Now meanwhile, I want to show you a small video on how to identify the CEAP classification of varicose veins. Hello everyone, in this short video let's learn about the CEAP classification of varicose veins. C is clinical classification. Similarly, we have E for etiology, A for anatomy, and P for the pathology of the varicose veins. Now most of your questions are from the C, or that is the clinical classification of varicose veins, where it is classified from C1 to C6. Now this is where a lot of confusion arises. So very simple, remember the mnemonic veins. Okay, so all you have to do is you need to write C1 on top and start from C2 for the veins. Okay, so C2 is V, C3 is E, C4A is I, C4B is N, C5 is S, right, C6 below that. Now if you look at the expansion of each of them, so just remember C1 is reticular veins or telangiectasia, V for varicose veins, that is C2, C3E for edema, C4A I for itching, that means the patient can either have eczema or pigmentation, C4B is nodular appearance of the skin, that means lipodermatosclerosis, C5 is S, that is scarring, that means it's an ulcer which is already healed, and of course the last one will be C6, which is an active ulcer. Thank you. I hope that short video was very helpful for you guys. Okay, so thank you one and all for your patient listening. I hope this was a nice session. You have enjoyed yourselves. Just one point, I'll put up my email ID here, so if you have any doubts or questions, you can always reach out to me on the email ID, and I will add you on to a WhatsApp group where we discuss a lot of MCQs and latest questions that are coming up. Okay, so my email ID is lkanta.57, this is 5, okay, 57@gmail.com, and I repeat, please subscribe to the channel, click on the bell icon, download the app, please download the app. You have free content there for about 2 or 3 days. See a few topics, okay, and if you like it, then take a call whether you want to subscribe or not. It's not exactly directly a sales pitch, but at least have a look at it and see whether what we said make sense to you, and you can always give us a feedback as well, how we can make it a bit more interesting and how we can help you with more number of sessions like this if you think this was very helpful for you. One last thing that I want to clarify, I think the question was between Murphy's sign and right upper quadrant tenderness. Right upper quadrant tenderness, like I said, just tenderness is there. Murphy's sign is whenever I keep my hand in the right hypochondrium and I ask the patient to take a deep breath. Okay, when the patient takes a deep breath, the liver is pushed down, the inflamed gallbladder is also pushed down. So once the gallbladder touches my hand, the patient stops breathing. So arrest in inspiration is called as a Murphy's sign. So arrest in inspiration is Murphy's sign. Tenderness is just tenderness in that particular area. That is the difference between Murphy's sign and right hypochondrial tenderness. So thank you Shabir, thank you Deva Varshini, thank you Aishwarya, Himanshu, Sakshi. You guys have stuck endured me for these 3 hours right now. Okay, Sneha, you have asked, sir, can you please tell interns how to prepare for the exam and other important topics? So personally what I felt, Sneha, is as in when you're doing your posting, let us say you are in your surgery posting right now, you have access to all the apps. Like for example, you download the Manipal Medes app. So we have 80 hours worth of content. So even if you watch, let us say 2 hours or 3 hours in a day, by the time you finish your posting, you would have completed the entire surgery. Okay, entire surgery. So if you do this, trust me, you can easily score 80 to 90% of right answers without even having to sit and struggle and go through all the textbooks. That is one thing. So as and when you're in that particular posting, finish off the videos, or if you find an interesting case, go home the same day and watch the video on that particular topic. So by doing this, what happens is whatever you read, you tend to forget. But if you have seen something and if you have experienced it, the chance of it retaining in your mind is a lot more. So finish off the topic, finish off few MCQs. Trust me, you can crack these exams quite easily. These exams are not difficult. Okay, it's just the way you're trying to understand the topic. Like I said, if you get a grasp of the concept, it becomes very easy. And I had very good teachers who gave me like live examples, like how I told you how to remember, like the Lugol's iodine and all. Of course, that is something stupid which I made up. But this is how I tend to understand and learn concepts, and this is what I want to inculcate in you guys. Okay, it's not about mugging up. It's not about just reading from a textbook. You should be able to apply it to reality. So see the cases the same day, come and watch the video, even if you don't watch the entirety. Okay, watch the rapid revision videos, solve a few MCQs. And what I want, the idea of showing you that last video with that CEAP classification was that we have designed it like an Instagram reel, 1.5 minutes, 2 minutes, and these are important topics. So we have lots and lots of such videos, more than 100 or 200 such videos. Rather than being bored and scrolling through Instagram, you can go through all these videos where we even give you latest updates. So this is something called as a faculty connect, okay, where we have come up with these short videos which will engage your mind. So this is whenever you're taking a break, let us say you're tired after 2 hours of studying, watch these videos, that's all. Rather than, it is very short with small mnemonics which will hopefully stick in your mind. At least if it puts that thought in your brain, I think the job is done. Okay, so nothing more to add from my side. If there are any other questions which you want me to solve, I'll be happy to do that. So we'll wait for another 10-15 seconds. So meanwhile, I reiterate the fact, please subscribe to the channel, the YouTube channel. Okay, and all the faculty of Medace are also on Instagram. So if you follow us or if you put a mail across to me, I will add you to the WhatsApp groups. So all the faculty have their individual WhatsApp groups where we post important cases and questions, and also that it's free of cost. So you can just get into all of that. Okay. So if there are no other questions, thank you one and all for your very patient hearing, and I hope you have enjoyed this session, and we will wind up then. Okay, so thank you again very much for attending the session. And I repeat, YouTube channel, subscribe, bell icon, very important, click on the bell icon. Thank you.